You're in live now. Please go ahead.
Yeah. A very good evening. Just 1 minute. Let me get very good evening to one and all of you for this wonderful webinar on neuro-ophthalmology today. And the topic is unlocking neuro-ophthalmology, demystifying the afferent pathway. And it's really amazing when you actually look at it that we have the most prolific speakers with global presence in this webinar. And it's truly a delight. And my most heartfelt thanks to all of you for being there with us. So we have on our expert panel, Dr. Drew Carey, who is a professor of ophthalmology in the Division of Neuro-Ophthalmology at Wilmer Eye Institute. He specializes in neuro-ophthalmic disorders like optic neuritis, uveitis-related papillitis, ischemic and hereditary optic neuropathies. And his clinical and research interests includes unexplained visual loss using advanced imaging technologies to improve the diagnosis of vision loss and to better distinguish etiologies of optic neuropathies, and makes it so connected to this interesting webinar of ours. Thank you very much, Dr. Drew, for being with us. And we are truly happy to have with you, Dr. Prem. I remember my entire session of ARC webinars and in Neuro-Ophthalmology, there was none without you or Dr. Rashmin and Dr. Ambika. And I'm so touched that you agreed to participate, and there's so much of learning we have from you. And Dr. Prem is a professor in ophthalmology, neurology, and neurosurgery in the Department of Ophthalmology at the University of Colorado School of Medicine. He's also the Vice Chair for Academic Affairs and the Division Head of Neuro-Ophthalmology therein. Thank you very much, Dr. Prem. We are absolutely delighted to have you with us, Dr. Rashmin. Your practical way of approach in your whatever topic you take on, it gives so much learning to not just the neuro-ophthalmologists, even to general ophthalmologists or anterior segment people like us. And Dr. Rashmin is a senior consultant, neuropathologist, cataract and refractive surgeon from the Center for Sight group of hospitals based at Hyderabad. Thanks, Dr. Rashmin, for being with us today. Thank you very much, Dr. Ambika, again, for always being there for us to share knowledge and ensure that we get the best from our neuro-ophthalmology webinars. And she is a senior consultant neuro-ophthalmology from Shankar Nethralaya, Chennai. Moderating with me is Dr. Muralidhar, who is a man who has always got the right things going as far as anything educational is concerned with ophthalmology in Eye Foundation group of hospitals. And he's a senior consultant in glaucoma, pediatric ophthalmology, strabismus, and neuro-ophthalmology. And been a huge support for me through my ARC days to even now to all my Foundation webinars. Thanks, Murli, for being there with us. Dr. Murli, there is a small change in the sequence of speakers. You missed it out. So Dr. Allen will go third. Dr. Prem would be first. Dr. Drew would be second. Fourth would be Dr. Karman. And after that, we have to have Ambika in for her talk. Okay. So we shall go on with Dr. Prem Subramaniam, who is going to be talking to us on a very interesting topic, infiltrative optic neuropathies, when to suspect and how to proceed. So on to you, Dr. Prem.
Thank you so much, and really happy to participate in this today and talk about this topic, which I think fortunately doesn't come up all that often, but is really important because of the seriousness of the disease and vision loss that can occur in people who have this condition. I have no relevant financial disclosures, and so I'll start with a case. This is actually a case that came from India, which is why I selected it. It was published in EYEEDU, which is one of the publications of the American Academy of Ophthalmology. And I encourage all of you out there who are trainees, this is available online, to read these cases because they're very instructive. So this was a 62-year-old woman who had presented with a couple of weeks of blurred vision in both of her eyes. She actually had absolutely no systemic symptoms. She was a farmer and she was living in the village and really just started having poor vision. And indeed, by the time she presented 2 weeks later, she had 660 vision in both eyes. She had sluggish pupils, but there was no RAPD. Very important, again, keep in mind, these are often bilateral processes. And so there may be no RAPD because both optic nerves, both eyes are affected. And the anterior segment was quite unremarkable in this patient. The vitreous really didn't show much at this point in time, but you can appreciate that the fundus exam showed that there was this hemorrhagic swelling of both optic nerves. And I think this is a picture that is very characteristic, although not every infiltrative optic neuropathy will have this kind of very swollen optic disc, very choked disc, I think is an old term that really applies in cases like this, because the infiltration is causing blood to back up, it's causing axoplasmic stasis, and so you can see right on the disc there is an extensive amount of hemorrhage, there are potentially cotton wool spots, there's blurring of the disc margins, and as a result, as we'll see in just a moment, there are a variety of entities in the differential diagnosis that may be important to consider in these patients. And so this is what was seen at this point in time, and an OCT was done. We'll come back to the utility of OCT, but you can see on the top, not surprisingly, that the RNFL thickness is markedly increased in this particular patient, but the ganglion cell complex, the GCIPL, which is in the lower half, is extremely thin. Remember, she's only had 2 weeks of vision loss, but this can be a clue as to what is actually happening in these patients with an infiltrative optic neuropathy. So let's just go through a little bit about the disease itself before we come back to what may have been happening in this case and how we approach patients. So it's optic nerve dysfunction that's due to a direct invasion by abnormal cells or organisms. And typically when we say abnormal cells, we're talking about malignant cells, often hematopoietic malignant cells. And then organisms, it can be bacteria, it can be virus, it can be fungus. And how it's distinct from a compressive optic neuropathy is there, even though there can be, again, tumor, there can be malignancy, it is typically surrounding the optic nerve, like in the optic nerve sheath or something intracranially or an intraorbital tumor that is compressing the optic nerve. And there's not a direct involvement of that process into the substance of the nerve itself. Similarly, inflammatory, there's crossover, right? If you have an infiltration of the optic nerve, you may see that there is inflammation as well that is generated. But unlike inflammatory optic neuropathy, it's not just the effect of inflammatory cytokines or the secondary edema that is caused by that, but rather, again, the direct action of the tumor cells or other types of inflammatory cells that get into the optic nerve itself. Again, ischemia can occur with the infiltration, but ischemia alone will not give typically that same kind of picture. And then demyelinating disease, you're usually not going to confuse with a infiltrative optic neuropathy. Now, the confusing thing about this is it can be acute, subacute, or chronic. It can present in any one of the ways that we think of for an optic neuropathy. So it should always be in your differential. I mentioned that there's a direct infiltration by the tumor cells. Now, inflammatory cells can do this as well, and I'll show you some examples of granulomatous inflammation in particular. Sarcoidosis is one disease that often will do this. TB, of course, in India always has to be kept in mind as a differential diagnosis for infiltrative optic neuropathy. And infectious organisms outside of TB include fungus characteristically that can give you a subacute or even a chronic infiltrative optic neuropathy. There is disruption of axonal transport, and then, as I mentioned already, there is swelling, cell death, ischemia. So again, there's crossover, but the primary process, again, is the infiltration that begins and then leads to these secondary reactions. It is not a primary ischemic or inflammatory process, and it can involve the nerve sheath of the surrounding meninges. Hematopoietic or hematologic malignancies are perhaps the ones that we see most frequently, especially in children, and I'll finish with that. But lymphoma and leukemia both can do this, and this can be the presenting sign of a hematologic malignancy. Why are breast and lung cancer likely to cause this? Because they're the most common malignancies in people in general. I don't think it's because there has been a demonstrated tropism for these tumors to the optic nerve. But melanoma, because it does have a tendency to spread to the leptomeninges, may be a little more likely to lead to an infiltrative optic neuropathy than perhaps other types of less common malignancies. Now, I mentioned things like sarcoidosis or GPA can give you an inflammatory process that then leads to a true infiltration of the optic nerve. And as I'll show you, you may see a granuloma at the optic nerve head that helps you to identify these cases. Other infectious causes, syphilis, TB, as I mentioned, and then fungus. But really, the ones that often present dramatically are going to be the neoplastic ones. And so patients generally will have a painless progressive vision loss. It is sometimes unilateral. It can be bilateral, but it is often unilateral. I mentioned at the beginning, if it's bilateral, there may not be an RAPD. Dyschromatopsia often present, just like we see with things like inflammatory or demyelinating optic neuropathies. The optic disc can be pale, swollen, or normal. It doesn't help you. And there can be possible orbital signs depending on if there is orbital infiltration as well. Things like proptosis or motility restriction can occur as well. So what's in our differential diagnosis? As you might imagine, optic neuritis, certainly, especially if there is pain. There may be pain because there can be headache pain if there is CNS involvement as well, along with the infiltrative optic neuropathy. You can have an ischemic process as well that can mimic this, although typically you won't see the same number of cotton wool spots or that very choked, hemorrhagic looking optic disc as I showed you at the beginning. Papilledema clearly has to be in the differential diagnosis. And again, this can be a mixed picture because if you have a patient who has a hematologic malignancy or a blood dyscrasia, as shown here in the differential diagnosis, that coagulopathy that coexists with the infiltrative optic neuropathy could lead to a venous sinus thrombosis and then give you true papilledema. So it's really important to keep in mind that there can be more than one process going on in a patient with infiltrative optic neuropathy, and that's why it's important to have a team approach to the management of these patients ultimately once the diagnosis is made. And then finally, if it's a patient who's had trauma, Terson syndrome can mimic this as well. It's generally, though, more insidious than optic neuritis, as I mentioned, usually painless, but unlike things like optic neuritis, there is rarely a spontaneous improvement. These patients generally keep getting worse. They don't even plateau. They just keep getting worse. And of course, if they have systemic symptoms, that may lead you to the diagnosis. MRI imaging is really important and often helpful in these patients. On T1, as shown here in the bottom right, you can see that there is often an enlargement of the optic nerve. When you see this, sorry, this is T2, but there's an enlargement of the optic nerve, and it is nicely demonstrated on the right compared to the left. You can see with gadolinium that there may be enhancement of the optic nerve or even the optic nerve sheath, and that can be confusing because, again, the infiltration can spread out of the optic nerve. But the difference here from a compressive optic neuropathy is that you have enlargement of the optic nerve in addition to the gadolinium enhancement. And even an axial image shown here shows this shaggy enlargement of that same optic nerve in this patient who had infiltration by melanoma. You may see diffuse thickening or focal nodule, and that's common at the orbital apex or in the intracanalicular segment. Visual fields, yeah, yes, you should do them, but they are not going to give you a characteristic defining defect. It can be central, altitudinal, whatever. Similarly, RNFL at the onset usually thickened because there's axoplasmic stasis, there's swelling, there's even frank disc edema. But the GCC, if it is thinned early, that can be a characteristic sign of infiltration and early cell death. Lumbar puncture with CSF cytology, flow cytometry to look for malignant cells, helpful, but it can be negative, and don't let that dissuade you from thinking the patient may have an infiltrative optic neuropathy, and then we should do serologies for those infectious and inflammatory disorders. Getting a detailed history, always in neuro-ophthalmology, we want to do that. MRI, as I mentioned, we want to be sure to get MRI, brain and orbits with contrast, with fat suppression to get good views of the optic nerve. Things like CBC, ESR, CRP, shown here, lumbar punctures I mentioned, and it may go as far as needing an orbital or optic nerve sheath biopsy if some of these other tests are not revealing. But let's go back to that first case. There, a blood count was done and showed a mild anemia, but more importantly, an extremely elevated white blood cell count, decreased platelets, an abnormal peripheral smear, and this was an acute presentation of leukemia. A PET scan showed abnormal foci of uptake, and this patient was sent for chemotherapy, as well as radiotherapy may be needed to improve the function at the optic nerves. And indeed, this is a different case of a younger man presenting again 2 weeks of vision loss to NLP. Can optic neuritis do this? Of course. But this patient had an elevated CSF protein. There were no malignant cells that were seen. He did have systemic symptoms and actually was admitted to hospital because of GI distress and diarrhea. And we're not used to looking at pelvic CTs as shown here in figure D at the bottom, but you can appreciate the figure C showing that there was some posterior globe flattening from a mixed picture of elevated ICP from the CSF process, as well as a true infiltrative optic neuropathy. But then the blue arrow is pointing to an anal mass in this patient, and this was a metastatic carcinoma leading to the infiltrative optic neuropathy. Now, it's not all cancer. Each one of these three images of the optic nerve is an example of a granulomatous optic neuropathy associated either with sarcoidosis or tuberculosis. And the MRI here, this axial MRI with gadolinium contrast, shows enlargement of the lacrimal gland in a patient who had a sarcoid infiltrative optic neuropathy. So always keep that in the differential diagnosis. And again, as I mentioned, certainly in India, TB has to be there as well. What are our management principles? Well, here it's really important to treat the underlying cause. So it is essential that we figure out, is this malignancy? They may need chemotherapy or radiotherapy, both at the orbits to protect the optic nerves, but systemically as well. Corticosteroids or immunosuppressants may be necessary if this is an autoimmune disorder. We're going to target with antimicrobial therapy if it's infectious. Now, adjunctive corticosteroids may still be helpful even if it is malignancy, or if it's infection. But of course, you want to treat the primary disease first. And don't forget, remember that first case had massive GCC loss even at presentation. These patients may not recover to 6.6, 6.9, even 6.60 if they start at NLP, and they may need supportive care with low vision aids, and if it's unilateral, to monitor the fellow eye to make sure that disease is not progressing. Not surprisingly, the best prognosis is with early identification and treatment, and malignant infiltration often has the poorest visual prognosis. But I'll finish by saying we never give up with these patients. This was a patient who was presented to me once when I was at a conference in India from a colleague who had a 17-year-old girl who had T-cell ALL, already known to have malignancy with CNS involvement. She developed bilateral optic disc edema. You can see very poor vision, especially in her left eye, had an RAPD because the left eye was more involved. MRI, MRP were actually inconclusive. It was unclear if there was infiltration of the optic nerves. There was no venous sinus thrombosis. Remember, I said you have to look for that. And there was no other clear evidence that the optic pathways were involved. And she had a lumbar puncture, normal opening pressure, no malignant cells, normal protein, and she was actually already getting intrathecal chemotherapy. And so there was hesitance to do anything more. But she had worsening eye pain and headache. She was given steroids. That didn't do anything. And then finally, I said, look, try orbital radiotherapy. I'm really concerned this patient could have infiltrative optic neuropathy. And orbital radiotherapy was done after some hesitation, and her vision recovered to 6.6 and 6.9, and the disc edema resolved. And so it's really important, again, that we have to suspect infiltration in a progressive painless optic neuropathy when we have a patient with the right clinical picture, take a complete history, do the systemic evaluation, especially the MRI as well, and a multidisciplinary approach is essential for diagnosis and treatment. And thank you very much.
That was truly a very interesting talk. So much of a variety also. So Murli, can you take some questions? And I would be very much obliged if our expert panel could add in their thoughts and questions too.
Dr. Prem, you had mentioned optic nerve sheath biopsy. So how often is it that you actually end up taking an optic nerve sheath biopsy? I mean, do you get adequate material for histopathology?
So this is a great question, and there was just a paper, I think it was just published ahead of print online in the Journal of Neuro-Ophthalmology, where they looked at the experience in the 3 Mayo Clinic sites. And you're right, it's not that commonly done, but it's essential, as you said, to get an appropriate biopsy. When you're going to go and biopsy, be sure to take a proper specimen, because the number one reason for getting an inconclusive result is taking inadequate tissue. So I think that we are most likely to do it, of course, when the patient has been PL or NPL for some weeks, because there is a thought that their likelihood of recovery, and especially when we think now that the fellow eye is at risk. And so in that series, at least, it showed at least a 70% positivity rate for getting an answer to an unknown question of why the patient had optic neuropathy and changing how the patient was treated. So I do think it's not done commonly, but when you do it, you should be, I hate to say aggressive, but as a surgeon, I will say that you need to get a proper specimen in order to get an answer.
So a very basic question, when you do CSF for these patients, would you think of taking a larger volume of CSF if you suspect something more?
Absolutely. This should be a large volume lumbar puncture, and the oncologist will tell us that sometimes it requires 3 large volume lumbar punctures done at different times in order not to miss the malignant cells. There are lots of studies in the cancer literature showing that MRI and looking for enhancement of the leptomeninges is probably more sensitive than lumbar puncture. But again, in that last case that I showed you, MRI and CSF can be negative. One can be positive, one can be negative. So it's really important to do both of those things, as you just mentioned.
So how often is it, Dr. Prem, that a patient has presented with infiltrative optic neuropathy in one or both eyes, and subsequent investigation has led to an undiscovered malignancy? I mean, do you come across that kind of a situation often?
It's not often, but I think that there is a definite percentage of these patients who present in that way. So I would say it's not 90%, but it's also not 5%. It's probably at least a quarter of patients who present to the ophthalmologist will then have a discovery of the systemic disease that they didn't know they had.
Okay. Dr. Drew, would you want to add anything at this point of time?
I think that was an excellent talk by Dr. Subramanian. I think the other scenario is sometimes you know the diagnosis, like it looks like a typical optic pathway glioma, but the biopsy can then guide your treatment in addition to diagnosis, because they can do molecular studies that may reveal specific mutations via next-gen sequencing that may allow for targeted therapies. And that can be for optic pathway gliomas as well as leukemias, lymphomas, and other tumors. And so biopsy can be helpful in those situations as well.
Dr. Rashmin, you have anything to add before we go on to our next speaker?
No, I think a great talk as usual, Prem. We have seen, of course, this doesn't make a benchmark, but we had seen a patient who presented like one of the hallmark clinically of infiltrative optic neuropathy would be a very angry looking disc. The disc edema would be much more profound than, let's say, what you find in other causes of disc edema. So we had a patient who clinically looked like having an infiltrative optic neuropathy. The MRI confirmed really a very thick nose. But when the lumbar puncture was done, the patient was found to have cryptococcal optic neuritis. I mean, so as Prem mentioned, infective causes is something which you should always be on the lookout for, apart from malignancies.
Okay. Thank you so much.
I just have one doubt, Dr. Prem. In one of the cases, you had mentioned that you had subjected the patient for a radiotherapy. So what will be your cutoff point when you decide that such infiltrative cases can be going for a radiation treatment also? Which is your second or third line? How do you decide?
Sure. So I think in this patient, right, was already receiving intrathecal chemotherapy, and that was not affecting the vision or affecting the disc swelling. She had IVMP as well, and that did not result in any improvement. So I think that if you tried those two modalities, then orbital radiotherapy, especially in someone who has a leukemia or lymphoma, because those tend to be so radiosensitive, you don't have to give high dose. And leukemia or lymphoma often will just melt away when you deliver the orbital radiotherapy. But just as you said, you typically would go with the systemic or intrathecal chemotherapy first, especially in the setting of a known malignancy like that.
Okay, thank you. Thank you very much, Dr. Prem. Do stay on with us. I'm sure we will learn a lot more over the next couple of hours. We go on to our next speaker, Dr. Drew Carey, who is the professor of ophthalmology in the Division of Neuro-Ophthalmology at Wilmer Eye Institute. And I've already introduced him, and he's going to be talking to us on hereditary optic neuropathies, what every clinician should know. So on to you, Dr. Drew.
Thank you so much for inviting me to participate in this excellent lecture. I'm thrilled to discuss one of my passions, which is the genetic optic neuropathies. So we'll go ahead and get started. I don't have any relevant financial conflicts for this talk. We are going to be discussing ways to help identify patients with possible genetic optic neuropathies, classify patients by inheritance patterns, and recognize some systemic manifestations. In general, in neuro-ophthalmology, we like to, categorize our patients. Are they coming in with an afferent disease, something affecting the retina or the optic pathways, resulting in decreased vision, central vision loss, peripheral vision loss, versus a patient who has efferent disease, such as a cranial neuropathy or disorder of the neuromuscular junctions or orbital myopathy, resulting in impaired eye movements that could result in double vision or loss of depth perception. I think we all know that sometimes these topics are not mutually exclusive and we have patients who overlap. Similarly, in ocular genetics, we often try to determine, is this an isolated ocular disease or is this a syndromic disease? And I wish it was always this simple, but sometimes these overlap both clinically and molecularly as well, and we'll get into that. I cannot discuss every gene involved in genetic optic neuropathies in the amount of time that has been allotted to me. So a quick snapshot. These are all the known autosomal dominant genes. Ones we're most common with are OPA1, OPA3, and Wolfram syndrome type 1 gene, but there is a lot. This is a quick review of all the autosomal recessive genes. And OPA1 can cause recessive presentations as well as Wolfram syndrome type 1. And then the X-linked genes are much less common. And there are a number of mitochondrial genes that can result in ocular neuro-ophthalmic diseases as well, both afferent and efferent. So instead of trying to discuss each gene, I thought we'd talk about some archetypes. In afferent disease, we have patients with the nuclear genes, autosomal dominant pattern. Most commonly, we see dominant optic atrophy. And our archetype for autosomal recessive is the Wolfram syndrome, also known as DIDMAUD. And then our mitochondrial archetype is Leber's hereditary optic neuropathy. I'm not going to spend as much time on efferent disease, but kind of our archetypes for congenital cranial nerve disinnervation syndromes is Duane syndrome and congenital EOM fibrosis. CPEO is our archetype for mitochondrial efferent disease, and then there's Friedreich's ataxia. Dominant optic atrophy, the most common gene for this is OPA1. It represents about 70% of dominant optic atrophy. It's located on the Q arm of chromosome 3. It encodes a mitochondrial dynamine-like GTPase. And it helps to maintain the stability of the mitochondrial inner membrane. So even though it is encoded in the nuclear genome, the protein is actually transported to the mitochondria where it performs its function. The prevalence varies across nations. In Denmark, it's as high as 1 in 10,000 people. In the UK, it's as roughly 1 in 35,000 people. It exhibits variable expressivity. So even the same mutation in the same family can have variable presentations. Visual acuity can range from 20/20 to 2200. It does tend to have a slow decline over decades. In the textbooks, it says you lose about 1 line of vision each decade. Often patients will have moderate disc cupping and temporal pallor. It is commonly misdiagnosed as normal tension glaucoma in adults or as amblyopia in children. Patients invariably have dyschromatopsia that is often worse than their visual acuity. And the visual field may show secocentral scotomas, or in automated testing, it may show more of Jerem arcuates due to the patients developing eccentric fixation. And on the OCT, surprisingly, rather than seeing temporal thinning on the RNFL, we typically will see superior and inferior thinning, and the ganglion cell usually shows diffuse and severe thinning. So here's an example of this. We have a 35-year-old male whose at presentation is 2100 in each eye. He's unable to detect any of the Ishihara color plates. He recalls at onset, since age 12, of trouble with central vision, color vision, and contrast. He reports it's painless, slowly progressive, and he thinks maybe his mother's brother is similarly impacted, but not really sure. Thinks mom is pretty normal, and it's not an uncommon family history when you take this. Now, if you were to examine these family members, you might be able to detect some differences, but because this is early onset and is slowly progressive, many patients, especially if mild, won't even really appreciate that they have any deficits. They think their vision is kind of normal for them. He did undergo genetic testing, which identified a deletion in the OPA1 gene. And these are his pseudocolor photos, and you can see there's some cupping of the optic nerve and temporal disc pallor bilaterally. And did not include the red-free versions, but you can see there's this nerve fiber layer defects corresponding to the papillomacular bundle. And on the automated visual field testing, these are secocentral scotomas. You might look at that and say, this looks like, bitemporal, paracentral. But if you were to do a Goldman visual field, you would appreciate that these are secocentral scotomas. In addition, the patient has reduced foveal sensitivities. This is another patient, a 50-year-old female, 2100 in both eyes, able to detect gross colors 2 out of 4. And she recalls at age 20 trouble with her central vision, color vision, and contrast, also painless, slowly progressive, and her family history was negative. She underwent genetic testing, which identified a splice site variant, which is known to be pathogenic. On her color photos, you can see she has some moderate cupping, maybe 0.5, and temporal pallor bilaterally in the optic nerves. And her visual fields look, on the pattern deviation pretty close to normal, but she does have reduced foveal sensitivities. And on the total deviation, you can see she has this paracentral scotoma, which is probably a mild secocentral scotoma. Dominant optic atrophy genes, particularly OPA1, can have what we typically think of them as isolated. They can have syndromic manifestations. We call this DOA+. Patients can have ataxia, either muscle hypotonia or spasticity. They can have deafness. They can have progressive external ophthalmoplegia. They can have peripheral neuropathies, and severe cases can even cause multi-organ failure mimicking Leigh syndrome. So it's important to take a good systemic review of systems when seeing patients suspected of dominant optic atrophy. Some of these may not be severe manifestations, and because it's a slowly progressive thing, patients may not really be aware of it or may have kind of brushed it off as just, oh, I'm getting older kind of thing. Moving on to our autosomal recessive archetype Wolfram syndrome, often called DIDMAUD, and that's because of the syndromic manifestations of diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. The most common gene for this is WFS1, and it's about 1 per 750,000 prevalence. This one is located on P arm of chromosome 4. I did not pick these genes because of their sequential chromosomal involvement. It's just a coincidence that we went from chromosome 3 to chromosome 4. I promise not to go through every chromosome in the human genome. It encodes wolframin protein, which is an endoplasmic reticulum transmembrane glycoprotein. It has highest expression in pancreatic islet cells as well as the brain and heart, but it is expressed in all tissues. It's also involved in early embryonic lens development. The exact function is unclear, but it's thought to be an endoplasmic reticulum calcium channel. The other genes, WFS2, also called CISD2, may cause similar phenotypes, but they're much rarer. Those are also interestingly located on chromosome 4, although it's the Q arm, and also involved in endoplasmic reticulum and mitochondrial membrane calcium homeostasis. These less common genes also cause disorders in platelet aggregation and peptic ulcers. So patients can have easy bruising, bleeding, and melena and iron deficiency. Patients with Wolfram syndrome are thought to be obligate type 1 diabetics and optic atrophy presenting in early childhood, although not all patients will actually have diabetes. It's greater than 90% will have type 1 diabetes due to pancreatic failure. 45% of the patients only have a complete syndrome. So most patients do not have DI and optic atrophy and deafness. About 60% will develop diabetes insipidus or hearing impairment at some point in time. Neurogenic bladder is an under-recognized manifestation of this disorder due to peripheral neuropathies, and their peripheral neuropathy involving the feet and hands are much lower. And neuropsychiatric symptoms are not uncommon as well. So it's really helpful when you're seeing a patient with Wolfram syndrome to have a multidisciplinary approach with a genetic counselor, a neurologist, a psychologist, or psychiatrist. And these other manifestations may develop over time. Here's an example of a patient with Wolfram syndrome. She had diabetes type 1 onset at age 2 and decreased central vision and color vision beginning at age 17. She noticed she could no longer play Uno with her friends because she couldn't tell the colors on the cards. And her hearing loss developed at age 21. She underwent genetic testing and was found to have a homozygous, fairly large deletion of 24 base pairs or 25 base pairs in the WFS1 gene. And interestingly, in addition to her optic atrophy, she also had these hyperautofluorescent lesions along the arcades, more so nasally. And these turned out to be vitelliform deposits underneath the retina. And you can also see them on the infrared photos as well. These were her visual fields, and her visual fields kind of had this bitemporal appearance on automated testing, but these are actually central secocentral scotomas, as you can see on the Goldman visual fields. There are patients who have what's often referred to as an atypical Wolfram syndrome, and this may be an isolated optic neuropathy, or this systemic manifestations may be milder or much later in onset. And patients with a gain-of-function variant may present in an autosomal dominant fashion. The autosomal dominant cases are more common to be have isolated optic neuropathy. This is a 58-year-old referred to me from their glaucoma doctor asking, is this glaucoma or not? At age 49, the patient was found to have a slowly progressive visual field loss, subsequently diagnosed with glaucoma. And in her early 50s, she reported trouble with her color vision. She does not have diabetes or hearing loss. On subsequent review of systems, she did identify some balance issues in neurogenic bladder, and she is of a 100% Ashkenazi Jewish background. She was 20/40 in both eyes when I first saw her. Her IOP was 10 in both eyes on latanoprost. We did not have her pre-treatment IOP. She had mild thinning of her corneal pachymetries, and color vision was markedly impaired. On her visual field testing size 3, the right eye appeared to have a superior altitudinal scotoma, and the left eye was constricted, but worse temporally. And when we did a size 5 visual field, you could see that this visual fields were much worse temporally, very atypical for glaucoma. Of course, we did neuroimaging and it came back negative for any chiasmopathies. She underwent genetic testing, was identified to have this homozygous variant in the WFS1 gene, and this variant is actually very common among patients of Ashkenazi ancestry. It's 1% of patients of Ashkenazi ancestry will actually be carriers for this variant, and if you have both of them, then you manifest this optic neuropathy. It tends to be later in onset and a more mild presentation. Here we have her OCTs, and you could see why looking at her OCTs, somebody might think that this is glaucoma. She has average RNFL thinning in both eyes, 66 and 70. She has cupping 0.71, 0.67, superior and inferior thinning patterns, not uncommon for glaucoma. On examination, I think it's difficult to say there's definite pallor, perhaps more in the left eye than the right eye. And the ganglion cell was markedly thin in both eyes, certainly much worse than you might expect for somebody with her level of field loss. but it was worse temporally than nasally and a pattern not uncommon for glaucoma. We had taken her off her IOP drops and her pressures remained 11 and 10, telling us she most likely did not also have glaucoma. This is just Wolfram syndrome. Moving on to our mitochondrial archetype, we have Leber's hereditary optic neuropathy. This is one that we are all familiar with. The most common genes involved are mitochondrial genes ND4, ND6, ND1. And in the textbooks and the papers, it tells us that ND4 is most common, making up 75%. The other two mutations are around 10%. If you have a negative family history and you are of non-European heritage, these genes may actually only make up 17% of LHON. These are very typical for incomplete penetrance, often skipping generations. It's a much higher penetrance among males. The carrier rate in the UK may be as high as 1 in 300 in some studies, but the prevalence of vision loss in Europe is closer to 1 in 45,000. We think that men probably convert to vision loss in maybe 1 out of 2 cases and women 1 out of 10 cases. There are a number of environmental factors that may contribute to conversion. Patients will typically present with acute to subacute sequential or simultaneous vision loss over a period of weeks to months, although they may report that they have fluctuating vision with some good days and some bad days, but usually within 3 to 6 months, they just stop having good days. At the time of presentation, they may have mild or subclinical disc edema with delayed atrophy that takes months or years after vision loss occurs. Initially, the macular ganglion cell may show slight thickening in the prodromal phase, but atrophy usually sets in within a few weeks to months. Mitochondrial toxins may trigger the vision loss as well as metabolic stressors. So patients who are known carriers, we want to counsel them about avoiding mitochondrial toxins and avoid things like being dehydrated or hypoglycemic. Typical onset is in the teens or 20s, but it is not uncommon to see onset in the preteen eras or in the elderly. Here's an example of a 48-year-old male who had fluctuating vision for a year, but has had steady vision decline for the last 4 months. On his Humphrey visual fields, it almost looks like he has a right inferior quadrant tenopia, but this is due to eccentric fixation. These are actually central scotomas, more apparent on the Goldman visual fields. And at his presentation, 4 months into permanent vision loss, his RNFL thickness, normal, maybe a little bit above normal at 105 and 107. No cupping to speak of, but the ganglion cell shows this thinning. And in the right eye, it's a nasal predominant thinning, which is not uncommon for LHON. In the left eye, it's diffuse thinning, although you can see on the heat map, it is worse nasally. 10 months into his vision loss, the RNFL is thinner than it was at presentation, but still pretty close to normal range, 81 and 76, with some mild borderline superior thinning. The ganglion cell has continued to thin in both eyes until it's going to reach its plateau, usually within 3 to 6 months. LHON, we usually are seeing isolated ocular manifestations, but more and more coming to light, we can see systemic manifestations we often refer to as LHON+. Cardiac manifestations would be the most life-threatening version. Patients can have conduction defects in 25%, as well as a dilated cardiomyopathy, as well as early onset and advanced coronary artery disease, putting them at risk for acute myocardial infarction. Neurologic manifestations, they can have demyelination mimicking multiple sclerosis, including optic neuritis. Seizures, non-epileptic myoclonus, migraines are very common among patients with mitochondrial disease. They can have dystonias, peripheral neuropathies, tremor, and even posterior reversible encephalopathy syndrome, as well as white matter changes in the brain and spine that may be asymptomatic, but showing up on MRI scan. Mitochondrial deletions can also occur. There are a number of nuclear genes responsible for mitochondrial genome maintenance, but patients can also develop sporadic mitochondrial segment deletions. The mitochondrial genome is much more mutagenic than the nuclear genome, and there are hotspots for deletions around 13,000 500 to 14,000 base pairs, as well as around 16,070 base pairs. These will typically result in mitochondrial myopathies and chronic progressive external ophthalmoplegia, but these patients may have concomitant optic neuropathies or maculopathies, or may present primarily with afferent visual disorders. And we have a case series of patients we've published on this. Here's an example of a patient with a mitochondrial deletion syndrome. At onset at age 37, he developed blurred vision with subsequent ptosis, diplopia, and weakness. He was found to have 2 large segment mitochondrial deletions around 12,000 base pairs in size, but low heteroplasmy, only affecting about 15% of his cells. And here you can see on his external photo, he has partial ptosis on the right and an exotropia. He has severe constriction of his visual fields on Goldmann perimetry to size 5. And you can see he has optic disc pallor and cupping on his fundus photos images. And so this is an example of a patient who has mixed afferent and efferent presentation due to mitochondrial deletions. So some take-home points from this discussion. There are typical patterns of vision loss, slowly progressive, symmetric for our non-mitochondrial presentations, or the patient's going to have rapid to subacute progression, fluctuating of their vision that's either simultaneous or rapidly sequential within months, more typical of mitochondrial pattern of vision loss with LHON. There are typical patterns of inheritance that we see: dominant, maternal mitochondrial, sporadic, or recessive, and X-linked recessive. However, the exceptions are almost more the rule than the actual rules, because these are not uncommon. Single genes can have either isolated manifestations or syndromic features. The typical LHON presentation may also occur with autosomal recessive genes, and patients with mitochondrial myopathy and CPO may also have vision loss from optic neuropathies related to their mitochondrial disorders. Be cautious with patients who are diagnosed with glaucoma at a young age, especially with young age normal tension glaucoma. Normal tension glaucoma is really a disease of the elderly, unless we're talking about congenital glaucoma where patients are developing axial elongation rather than elevated IOP that's measurable. But people with onset in their teens and 20s and 30s, it's not normal tension glaucoma. Beware of patients diagnosed with glaucoma who have dyschromatopsia and reduced visual acuity. And beware of patients diagnosed with glaucoma where their ganglion cell is worse. Their ganglion cell thinning is worse than you would expect for their visual field or their OCT-RNFL. Toxic and nutritional insults may trigger LHON conversion. So patients with a clear toxic or nutritional injury who have large central scotomas, or they don't improve once the toxin is removed or their nutritional deficiency is replaced, you should consider that they have concomitant LHON. And that's my discussion. I'm happy to take any questions, or if folks need time for other presentations.
Very interesting talk, and you managed to make it so interesting. Like there's not a single slide any of us would have missed out, and so valuable information. So on to you, Murli.
Dr. Drew, I had a question for you. Whenever you suspect these hereditary optic neuropathies, what test would you order? Would you order a whole exome sequencing or or a targeted sequencing?
That's a great question. And you asked the answer I'm going to give you today is probably different than the one if you'd asked me 5 years ago, and it may be different than the one I'd give you 5 years from now. I think the first step is to try to characterize the phenotype as best as possible. Because when you order these panels, whether it's a targeted optic neuropathy panel, whether it is a whole genome or whole exome, we used to think, right, you have one disease and one gene and you send off your genetic testing that's going to give you the answer. And unfortunately, it's much more difficult than that. If they don't have a clear family history, oftentimes it's going to come back with multiple variants of unknown significance, or you may get their carrier in one gene and they have a genotype of another gene, or it may come back, inconclusive. There are disadvantages to exome and genome testing. You'd think, oh, you're getting more information, that's going to be the best option. The genome test, it only tests the portion of the gene that codes for a protein. It's not going to include any non-coding portion of the gene, which can be pathogenic. If you have a splice site variant, it's going to miss that. If there's a mutation in the promoter region so that the gene never can be encoded, you're going to miss that. For optic neuropathies, we're not, and there are genes we don't know about yet, or changes in genes we don't know about yet. In hereditary retinopathies, the most classic promoter gene or promoter variant for a gene is North Carolina macular dystrophy. It's an autosomal dominant condition. It was first described in like the 1940s or 1950s. They did not discover the gene until after 2010 because it was in a promoter region. So the advantage of a panel is that panel is going to include all the known variants that they include. If something got published yesterday, the panel may not be updated, but it's going to include those splice site variants, promoter region, all the non-coding variants that are there. So I think it's at the current stage, it's probably best to start with a targeted panel before going to genome or exome sequencing, because they're going to take a really in-depth, detailed look at that. Now, if it's something clearly syndromic, it may be better to start with a genome panel, because an optic neuropathy panel may not have all those syndromic genes in it. There are syndromic panels, but the overlap may not be perfect. So if it's something that doesn't fit a typical picture or it's clearly syndromic, it may be best to start with a genome panel.
Okay, thank you. Dr. Ambika, Dr. Rashmin, Dr. Prem, any of you have anything else to ask before we go on to our...
I know I didn't solve all the
Thank you.
questions.
Oh, sorry. Yeah, Prem.
Okay,
I
shall we
think the
go?
main takeaway, right, is there's always change. I'll let Alan take it from there.
Okay. Okay. Then we shall then go on to our Dr. Alan. Let me introduce him. Just 1 minute.
Well,
So we shall be going on to Professor Alan Palestine's talk now. And he's currently the Professor of Ophthalmology and Professor of Medicine Rheumatology at the University of Colorado School of Medicine. And he has been very much involved in ocular inflammations and studies of cytomegalovirus, retinitis, and AIDS, and use of cyclosporin in the treatment of uveitis, and has over 300 scientific manuscripts, and has participated as a clinical investigator in numerous pharmaceutical multi-center trials. His presently interests are educating residents and fellows in the care of patients with uveitis, as well as pursuing clinical research related to ocular inflammation. So I think he's just the right person to give us a contemporary clinical update on ocular syphilis. So we look forward to hearing you, Dr. Allen.
good evening. Thank you very much for inviting me today. And I'd like to talk about acquired ocular syphilis and emphasizing the posterior aspects of the disease. I have no relevant disclosures. So syphilis is an interesting disease. Basically, it's a disease of blame. Everybody blames everybody else. So how did syphilis get to Europe? Well, there's a Columbian hypothesis that syphilis was brought to Europe when Columbus returned in 1492, because the first documented epidemic cases of syphilis were in 1494. However, alternately, syphilis may have been present in Europe, but not sexually transmitted based on some recent gene studies, and then had an evolutionary change in the about 5 centuries ago, and that accounts for the epidemic. Either way, the English called it the French disease, the French called it the Neapolitan disease, the Russians called it the Polish disease, the Polish called it the Turkish disease. Basically, everybody wanted to blame everybody else. Regardless of where syphilis originally started, in the 1700s, 20% of London residents had contracted syphilis by age 35. In the 1800s, this was actually viewed as divine punishment for sin. We all know that Treponema pallidum is the cause of organism spread by intimate contact. It's highly infectious, and interestingly, even in this century, we can still not culture Treponema pallidum in vitro. Now, I always tell patients that the best news they could possibly have is that their ocular inflammation is due to syphilis. They don't usually have that reaction initially, but truthfully, it is the best news because it's the only disease of all diseases I see that I can actually cure. So Osler said to know syphilis is to know medicine, about 120 years ago. I'm not sure that's true today because we know a lot more about medicine. But syphilis can certainly affect every part of the body. And we can see that, there's a primary syphilis, which is a short incubation, spontaneously resolves, and asymptomatically seeds the rest of the body. Secondary syphilis occurs 6 to 8 weeks later and goes on for a period of 6 to 12 months with this generalized maculopapular rash that we're familiar with. And then latent syphilis goes on for years if it's not treated. This organism simply goes dormant and eventually shows up in late stages with basically any part of the body being able to be affected. Most of the syphilitic uveitis that we see is secondary syphilis, and we see it within 6 months of exposure and definitely within the first year. Tertiary syphilis has become much, much less common than it was in Osler's time, and rarely does a patient with syphilis progress to have the severe manifestations that were described in the early 20th century. So, we're always taught that we should suspect syphilis all the time, and hence we treat almost every patient with an ocular inflammation. We test them for syphilis, regardless of their age, whether they're 2 or 92, regardless of clinical history. But that testing is very, very low yield, except for specific risk groups and specific exam findings that I'm going to talk about. So I'm going to focus here on primarily the posterior segment involvement, which is optic neuritis, as well as some other changes, because this is really the syphilis that we tend to see mostly in this era. So how do we test for syphilis? Well, the original testing was using a non-treponemal test like the VDRL, which was developed in 1907, or the RPR. And these are non-specific. They can detect syphilis, but they can also be wrong. And if it was non-reactive, we concluded there was no syphilis. If it was reactive, we went on to more specific tests to confirm whether or not this was truly syphilis. But now we've gone to the specific tests first. So for most evaluations, we'll go with either ELISA or an FTABS as the first screening test because they've gotten much faster. And if they're not reactive, then the person by definition didn't have syphilis. If they're reactive, the non-treponemal test can be very useful because a non-treponemal test like an RPR being positive means they still have syphilis. But if it's negative, it becomes less likely that the patient actually has syphilis. Now, a lot of people talk about the CSF and neurosyphilis, and we can test the VDRL. Can't do some of these other tests. And the VDRL in the VDRL is not very sensitive. It's very specific in the CSF, but a negative test in the CSF does not rule out neurosyphilis. So how do we treat syphilis? Well, amazingly, syphilis is still easy to treat. It is sensitive to penicillin, and there's never been a resistant case of syphilis resistant to penicillin. One of the questions is syphilitic ocular disease truly neurosyphilis? And this is endlessly debated, and we really don't know the answer. Certainly when the optic nerve is involved, we're going to call it neurosyphilis. But it isn't necessarily true that if one has an anterior chamber reaction only and has anterior uveitis, that's truly neurosyphilis. On the other hand, since penicillin is the most effective treatment, it isn't particularly difficult to treat. The challenge is that we can use intramuscular penicillin if we're treating syphilis that is not neurosyphilis, but if we think ocular disease is truly neurosyphilis, then we need to use penicillin intravenously with a much more prolonged course. There are alternatives to penicillin, like doxycycline, but if at all possible, we do want to use penicillin. Immunoimpaired patients, HIV positive, for example, should definitely have IV penicillin. Remember that the syphilis IgG stays positive for life, whereas the RPR titer and the nonspecific titers will decrease with successful therapy. So if you see a patient who has a positive syphilis serology, but a negative RPR and other testing, they may not actually have active syphilis, and they may have gotten tested in the past, and then or they may have been treated in the past for a upper respiratory infection, because there are other alternatives like ceftriaxone or azithromycin, which will also successfully treat syphilis. So this is the most common form of syphilis that I see. I'm a uveitis expert, so I see a lot of inflammation in the back of the eye. And this is basically placoid posterior chororetinitis from syphilis. And you can see the scattered placoid lesions here. Initially, you can see in the OCT that there is loss of the outer segments and the damage to the outer retinal zones. And with penicillin, this improves tremendously. The patient ends up seeing very well. And this is an example of placoid syphilis. This patient presented 6 months prior. They had a rash. They were 41 years old. They eventually gave a history of blaming their boyfriend and had decreased vision in the left eye, which was the more severe one as far as macular involvement. But this has a very good prognosis, and that's why I tell people that if they have syphilis, that's the best news they could possibly have. So let's talk a little bit about syphilis and neuro-ophthalmology. So infectious optic neuropathy, especially due to syphilis, can present as optic nerve edema, anterior optic neuritis, or retrobulbar optic neuritis. It can be unilateral or bilateral. There are really no specific clinical findings. So that's, again, testing is always part of the workup for patients with optic nerve inflammation, and occasionally you'll find a patient with neurosyphilis. The prognosis, again, is pretty good, but it definitely indicates neurosyphilis, and we should treat with IV penicillin. Now, we can't talk about syphilis without talking about the Argyll-Robertson
Doctor,
pupil.
1 minute more.
I'm sorry?
No, it's okay. They're just saying that we have 1 minute more. Yeah, continue, doctor.
Oh, so, the Argyll-Robertson pupil, we're taught, is miotic. It reacts briskly to accommodation, but does not react to light, giving this near light dissociation. It was described in the 1860s in association with tertiary neurosyphilis patients. The problem is we don't see syphilis at this stage very often anymore. So we don't really see the widespread late neurosyphilis that was associated with the Argyll-Robertson pupil. We know that it's damage to the midbrain dorsal Edinburgh-Westphal nucleus, and it's not actually specific to syphilis. It can be seen in multiple sclerosis, neurosarcoid, diabetes, and trauma, so it's not absolutely diagnostic. However, it is a very often sought after sign, and we teach residents and fellows endlessly to look for this near light dissociation. In the current century, it is very rare, especially at least in the practice that we have. Most patients with syphilis don't get to late stage findings before they have some other finding leading to diagnosis and treatment. Remember, in the 1860s, there was no penicillin. In the early 1900s, there was no penicillin. So there was really not a good treatment for syphilis until penicillin became widespread post-World War II. And therefore, there was a lot of late-stage syphilis, and therefore, the Argyle-Robertson pupil was much more useful in the 1800s than it is now. So in Colorado, we have a rising epidemic of syphilis, and you can see that over here. In the United States, we have a rising epidemic of syphilis. I had trouble finding data about India and syphilis, but it seems that there is much less of an epidemic in India than there is in the United States and in Colorado. The highest risk factors are patients who are HIV positive, men who have sex with men, patients with multiple partners. There is now post-exposure prophylaxis. So we can counsel our patients that if they have unprotected sex, a single dose of 200 milligrams of doxycycline 72 hours, within 72 hours of exposure, reduces the syphilis rate by 70%. One of the other odd things about syphilis is that previous infections do not confer immunity. So a patient who's had syphilis can get it again, unless they change their habits of how they're possibly getting affected. So when should we really suspect syphilis? Because if we're going to test everybody, we're going to have a tremendous number of negative tests. And so, yes, syphilis can cause anterior uveitis. It can cause scleritis. It can cause conjunctivitis. But truthfully, we should suspect it when we have high-risk patients, like we talked about, patients who have a rash, patients who have a history of exposure, often which they won't admit unless you ask them more than once, patients who have optic disc edema or optic neuritis, patients with posterior uveitis, outer retinopathy, retinal vasculitis, as you can see in the photo here, and diffuse retinal whitening. Also be aware that no test is 100%. So we have seen patients for a variety of reasons who test negative for the initial syphilis screen, and a second test, because we're highly suspicious, turns positive. So we shouldn't necessarily think everybody has syphilis, but we might want to test them. But we also want to retest those people who are still suspicious. It is acceptable to treat the inflammation with corticosteroids when you're waiting for the test results, which are usually back within 24 hours. Lumbar puncture is really only worthwhile if it's going to change your therapy. If you've decided to treat the patient with IV penicillin, the lumbar puncture really doesn't add much. Remember to test intimate partners, and please, if you see an NAR pupil, make a video. Thank you very much. It's a pleasure to talk to you.
Thank you very much, Doctor. That was a very a lucid talk which you gave us, and so much of information. I look forward to the expert panel coming up with their set of questions. And Mundi, can you take the first one? Mundi, you have to unmute yourself.
Yeah, sorry. Dr. Palestine, it was a wonderful talk. Thanks so much. I have a question. You had mentioned that patients who present with optic disc edema or optic neuritis should also be routinely tested for syphilis. So would you test the high-risk groups, or is it a blanket recommendation that before you start or concurrently with any therapy, you should test them for syphilis?
Absolutely. So, I mean, one, syphilis is curable. So many of the other optic nerve inflammations we see are not. Number two, it's a relatively cheap and easily accessible test. It doesn't require 3 weeks waiting like it does for gene therapy. If you make a diagnosis of syphilis, you've solved the problem, you can cure the patient, and they have a good prognosis. So there's no reason not to test every patient with optic disc edema where there's any suspicion, unless you obviously have another cause like intracranial hypertension.
How often do you see the neuro-ophthalmic manifestation and the uveitic manifestation coexisting?
That's an excellent question. It is odd that most of the time we do not see these two aspects of syphilis coexisting. So I would say that the majority of the patients I see, again, I have a uveitis practice, do not have optic disc direct involvement. They may have some optic disc swelling that we might interpret as secondary from the inflammation. And the patients that I've seen with optic neuropathy, most of the time do not have true intraocular inflammation. So it is interesting that there is some dissociation, even though the two tissues are very close in the eye.
Okay.
I will say I test all my papilledema from elevated ICP patients for syphilis, right? They're usually young women, so they're an at-risk population, and so they can occur concomitantly, and neurosyphilis can also by itself cause elevated ICP. We get a lot of second opinions in neuro-ophthalmology for optic disc pallor, and I will invariably test them for syphilis because I didn't get to see them acutely. I don't know if they had a swollen nerve or not sometimes. But then you run into the challenge when it comes back positive, and you don't know if their presentation was actually consistent with an ocular manifestation of syphilis. Do you run into that? Do you have recommendations? You just treat them for neurosyphilis anyways. It's relatively safe.
I do, and that's one of the actual confusing problems in syphilis. So if you look at the hierarchy of how we list diagnoses, syphilis is always at the top. If you have a positive serology, by definition, we think you have syphilis. And that becomes a problem in people who have low RPRs, because the RPR may go not necessarily back to 0. It may still be positive at 1 to 2, even in previously treated syphilis. So we end up with a situation where we assume that everybody that has a positive IgG and a positive RPR has syphilis. Now, it may not be causing their eye disease. On the other hand, if they still have syphilis, it's still worth treating. So I think that we end up treating patients who do not necessarily have active syphilis as the cause of their inflammation, but they have a positive test. And, in essence, we're doing them a favor in treating it anyway. But we do have to bear in mind that not every patient that has a positive test will necessarily have their eye disease related to syphilis. And if you think back to the 1700s, when 20% of London was positive for syphilis, clearly they would have made that diagnosis of syphilitic uveitis or syphilitic optic neuritis a lot, and yet most of those patients might have just had uveitis or optic neuritis from other causes. But I think it's an easy enough curable disease to treat, and so when you're not sure, treating is the better choice.
Yes. Thank you so much, Dr. Allen. Thanks for being with us and giving us such an informative lecture.
Thank you for
We go
inviting me.
we go on to our next speaker, Professor Carmen Chan, and she's the consultant ophthalmologist and chief of services at Hong Kong Eye Hospital, and also the honorary clinical professor, Department of Ophthalmology and Visual Sciences of Chinese University of Hong Kong, and honorary clinical professor, the Department of Ophthalmology School of Clinical Medicine, Hong Kong University. And again, her research focuses on ocular imaging for non-glaucomatous optic neuropathies and diabetic retinopathies utilizing AI tools. Besides having published over 80 papers in the most popular journals, the most interesting thing is that she has been selected as one of the top 100 ophthalmologists in the Asia-Pacific region in 2022 and 2025. Congratulations to you, Dr. Chan. We are truly enlightened to have such an prolific personality amidst us. And she is going to be talking on retinopathy versus optic neuropathy, unraveling subtle clues in history and examination. On to you, Dr. Carmen.
Thank you. Can you see my slides?
Yes, we can.
Thank you. So first, I'd like to thank the organizers for inviting me to this webinar, and it's really a pleasure to speak amongst very distinguished speakers this evening for me. I'm also grateful for the organizer for assigning me this topic of retinopathy versus optic neuropathy, because just like Dr. Palestine, I also do uveitis. So patients with, basically visual loss of a known cause, and they don't know whether it's optic neuropathy or retinopathy, will probably end up in my consultation room. So I don't have any, my slides are not moving. Oops. I don't have any financial proprietary interest. Okay, so to distinguish between retinopathy, maculopathy, or optic neuropathy is easy when there's something to see in the fundus. So the difficulty arises when the fundus appears near normal with no disc swelling and nothing particular in the macula or the retina. I say near normal because in most of these cases, although it looks normal, but if you look really carefully, you can actually spot something very subtle. So I dilate all my patients referring to I dilate all my patients even when they are referred to the neuro-ophthalmology when they come to see me for the first time. So I think we can broadly divide them into those with acute presentation and those with chronic presentation. So those which can mimic acute optic neuritis include the white dot syndrome, for example, acute zonal outer occult retinopathy, AZUR, or acute idiopathic blind spot enlargement syndrome, or mutes. In the beginning, you should be able to see the white spots in mutes, but they are usually evanescent, which means if the resident who saw the patient for the first time didn't take a fundus photo, if the patient comes back to see you 2 weeks afterwards, there'll be nothing to see, and then you're at a loss, and then you'll be asking the resident, are you sure you saw the white spots or not? And another condition is ciliary-retinal artery occlusion after the acute phase, because, for example, the first 2 weeks, you may be able to see something in the retina like a cherry red spot, but you may not see anything else afterwards, and there will be no RAPD to help you. And two other conditions which are quite uncommon, acute macular neuroretinopathy, which affects the outer retina, and usually there are some subtle macular changes, and also PAM, which has become is an OCT diagnosis, which is becoming quite a popular popular term in recent years because of the OCT aspect, and that affects in the retina. For chronic diseases like cone rod dystrophy or retinitis pigmentosa sine pigmento, actually can present like normal tension glaucoma, like Dr. Carey mentioned just now. And occult macular dystrophy, in a lot of these cases, previously they were told to have entirely normal fundus, and this would be diagnosed on electrophysiology. But nowadays with the OCT, in a lot of these cases, there'll be subtle OCT changes. Cancer and melanoma associated retinopathy, and also early toxic retinopathies and early toxic retinopathies, like those caused by hydroxychloroquine or tamoxifen. So how to differentiate between retinopathy and optic neuropathy when the fungi appear almost normal? As with everything else in medicine and everything else in neuro-ophthalmology, is based on history, examination, and investigation. In terms of the history, the onset, because both retinopathy, maculopathy, and optic neuropathies can be acute, subacute, or chronic in the onset. So I don't think that helps too much. But what really does help is that pain, because it's almost always absent in retinopathy, but it's common in optic neuropathies, particularly in optic neuritis, when there's usually pain with eye movement. Also positive visual phenomena like photopsias, which are common in retinopathies and rare in optic neuropathies, and metamorphopsias, which affects retinopathy much more. Well, only present in maculopathies and not in optic neuropathies. This chromatopsia is frequent in optic neuropathies, is rarer in retinopathies, but still can happen when the macula is involved. In terms of systemic diseases, in both retinopathies and optic neuropathies, there can be preceding viral illnesses, or the patient may have autoimmune diseases. Obviously, if they have multiple sclerosis, then you of course think about optic neuritis. Malignancies can manifest as both retinopathy and optic neuropathies. And we should also take a careful history when it comes to medication, nutritional causes, and also family history as well. Examination. Well, apart from the near normal retina, the one is the brightness and saturation. In optic neuropathy, it is a common finding. In a retinopathy, it is usually absent if the macula only is involved. The color vision is usually normal in retinopathies unless the central macula is involved, whereas in optic neuritis, it is usually one of the most prominent features. However, in in cases like NAION, of course, the central vision and color vision is well preserved. But you should be able to tell NAION from retinopathies anyway, because by definition, NAION would have the swelling at the onset. RAPD is common in optic neuropathies unless it's bilateral symmetrical, whereas in retinopathies it's rare unless it is asymmetric or severe. Fundal appearances, there can be subtle swelling in optic neuropathies which are not detected clinically, so OCT RNFL can be very helpful. And the fundus appearance there can be subtle changes in retinopathies, so an OCT can really help you in that way. So we'll look at some examples in a minute. There are two other tests that you will read in textbooks: the photo stress test and the Pulfrich phenomenon. I don't normally do them, but I've included them for completeness. So the photo stress test is you shine a bright light using the ophthalmoscope at the eye for 10 seconds and see how long the patient takes to recover their ability to read within one line of what they could see on the Stern chart previously. So optic neuropathies is quick, whereas in retinopathy, it can take up to 1.5 minutes to 3 minutes. And the Pulfrich phenomenon is when you swing a pendulum in front of the eye. So when in retinopathies, it will be negative, whereas in optic neuropathies, provided that they have reasonable vision in both eyes, they may see the pendulum moving in a circle rather than just from left to right. Okay, investigations. When it comes to the investigation principle, we have to know that in retinal conditions, if they're extensive enough, it can lead to optic neuropathies. Therefore, in both retinal and optic nerve diseases, there can be dyspallor and also thinning of the RNFL and GCIPL on OCT from 2 months onwards, because at the onset it's going to be normal, unless that there's some subtle the swelling then can detect it on the increased RNFL. If you were to do the VEP immediately, whether it's due to a retinal cause or optic nerve cause, it will be abnormal. Whereas in primary optic nerve disease, the retina is normal. So no matter how severe the optic nerve disease is, the retina is going to be normal with normal standard full field and multiple focal ERG. But if you were going to do the photopic negative response or look at the N95 on the pattern ERG, it will be abnormal. Primary optic nerve disease although there will be no abnormality in the outer retina on the OCT, it can still cause macular and GCIPL thinning on OCT. Okay, so OCT, those of you who know me will know that it's my favorite investigation. So it's always my first line in these cases, plus a combined fundus autofluorescence, which is easily done at the same time, and also electrodiagnostics as well. So OCT modalities, of course, all of us are very familiar with the conventional axial scans, which are useful for retinal abnormalities, but also the RNFL, GCIPL, and total retinal thickness, which can actually show you subtle abnormalities, which I will illustrate with some examples in a minute. On fast imaging can be nice to show AM&R and PAM, and OCT angiography is good for ischemic maculopathies. Okay, we're all very familiar with that, and normally as ophthalmologists, we look for example, subretinal fluid, macular edema. But in these cases where there's nothing to see clinically, we're more interested in, for example, the outer retina finer structures like the ellipsoid zone, previously known as the inner retina IS-OS junction, and also the inner retina as well. So the outer plexiform and the inner plexiform and inner nuclear layers. So in a subtle maculopathy or retinopathies, for example, in this patient with acute loss of vision for 3 days in the right eye, the fundus appear normal, there's an RAPD, so is this retrobulbar optic neuritis? Of course not, because I'm sure those of you who are astute we'll see that there's an abnormal ellipsoid zone, and in fact, this is a case of acute zonal occult outer retinopathy. OCT is great for monitoring toxic optic neuropathies as well. For example, hydroxychloroquine or tamoxifen. So just now we mentioned that it could also mimic optic neuropathies, especially in the early stages when there's nothing to see. So in this case, where this patient had regular monitoring for hydroxychloroquine maculopathy. So in this case, the patient had an OCT scan in 2023 and then a repeat one in 2024. The resident who saw this patient, in fact, did not spot the abnormality. But given the comparison, you can actually see that the blue zone of retinal thinning has actually enlarged in the left eye over this year. So if we were to look at the OCT axial scan, yes, the center looks normal. However, there is actually loss of the ellipsoid zone just outside the central macula, which corresponds to the thinning. And this is characteristic of hydroxychloroquine retinopathy or maculopathy. In fact, in the right eye, if we actually go back and have a look at the right eye here, in the temporal inferior retina, there's also some blue emerging, which means there's thinning there. So in fact, there's also early retinopathy there as well. So the diagnosis here is early bilateral hydroxychloroquine maculopathy, and the hydroxychloroquine was terminated. Okay, fundus autofluorescence is very good because it's non-invasive. There's self-induced fluorescence from RPE lipofuscin. There's no exogenous fluorescent agent. It can detect subtle RPE abnormalities, which are not otherwise noted on clinical examination. For example, in this patient who presents with right eye enlarged blind spot or central scotoma, there was nothing to see on the fundal exam, and she had fundus autofluorescence, which showed a subtle abnormality there. So can this abnormality there on the right eye? So at this point, you were thinking, well, it's so subtle. Is this the cause of it, or it's an coincidental finding? So in fact, if we subsequently did the multifocal ERG, it confirms that this is in fact a maculopathy, a bilateral one, in fact, and not an optic neuropathy. So this brings me nicely into the next topic, which is electrophysiology, which currently I only do as an investigation of last resort. So that's my personal preference, but I'm sure some of you in the audience might disagree with me. So traditionally, to distinguish between retinopathy and optic neuropathy, the first line of electrodiagnostic testing is pattern ERG, in which there could be, in retinal disease, there could be a reduction of the P50 amplitude, whereas in optic nerve diseases, there can be a reduction in N95 amplitude. And so in normal cases, the N95 over P50 ratio should be greater than 1.3. This diagram is only here to remind us that the stimulus in pattern ERG is a checkerboard pattern. Full field ERG is very useful for detecting, for example, retinitis, pigmentosa sine pigmento, cancer or melanoma associated retinopathy, or cone dystrophies in which there are widespread retinal dysfunction. A multifocal ERG is useful for detecting localized macular pathology when there's no abnormality on the OCT. And the N1, it corresponds to the photoreceptors like the A wave and full field ERG, and the P1 corresponds to the bipolar and Mueller cells like the B wave in the full field ERG. So the real electrophysiologists will always just look at the trace arrays and the group averages, whereas those of us mere mortals will probably just look at the color plots, which in fact is optional, but it can be a very nice illustration of of the pathology. However, we really have to be careful to note that in multifocal ERG is very dependent on the patient's fixation. So if the patient's fixation is just a bit off because the vision is poor, then it can totally throw the results into disarray. Okay, let's illustrate with a couple of cases. So this patient is a 31-year-old female teacher, mild myope. So painless decrease in vision in the left eye for 3 days with blue photopsia. So just a little decrease in vision with 20/25 and a little impairment of color vision, still able to read 13 out of 16 plates of Ishihara. There's an RAPD, there's red desaturation. There's nothing to see in the fundus except some mild RV mottling. So this is in this juncture, because there's photopsia and painless, you would think, well, this is probably a retinopathy. And this is the corresponding visual field as well. So, but she went on and had MRI, which showed a mild enhancement of the canalicular portion of the left optic nerve, and that was what was reported. So, given the MRI findings, she was treated as retrobulbar neuritis, retrobulbar optic neuritis, and 2 months later, the visual acuity normalized. The visual field defect was smaller, that the RAPD was still present, so everything was still consistent with a past episode of retrobulbar optic neuritis, except that at that time when we did the RNFL thickness, it was both eyes normal and symmetrical, which is not what we would expect, because even with a good visual recovery, we would still expect the RNFL to be decreased in the eye with the presumed optic neuritis. So we actually did electrodiagnostics. So in this case, the P100 implicit time was normal, but the left eye, the amplitude was a little bit decreased. And when we did the pattern ERG, the P50 was decreased, whereas the N95 was preserved. At this time, we were very suspicious of a retinopathy. And when we did the full field ERG, indeed, the scotopic responses were normal, but the photopic cone responses were decreased, including the 30 Hz flicker. So it actually demonstrated a global cone dysfunction. So the final diagnosis was acute outer zonal occult retinopathy. Okay, moving quickly onto the second case. So this gentleman was referred with right eye optic neuritis from the outside center. So presumed optic neuritis due to painless visual loss in the right eye. So at that time, the right eye, the vision was at 4/200 at nadir, but the left eye vision was also decreased, and at 20/50, although he was asymptomatic in the left eye, there was bilateral scotomas. There was impaired vision in both eyes, impaired color vision in both eyes, and he could only read the test plate with Ishihara. There was no RAPD, the fundi was normal, no diswelling. The MRI, anti-MOG and anti-NMO antibody was negative, and there was also no family history. So he was given a course of IP methotrexate anyway, but with a subjective decrease in his scotoma. And in fact, his vision did improve to right eye 120 and left eye 20/20. However, 6 months later, he developed a new scotoma in the left eye, and he declined the offer of IV steroid, and he was somehow given a course of oral steroid, which was tapered off in 2 months. But this time, the vision did not recover. So the vision was still 20/200 in the right eye and 20/50 in the left eye. So just looking at the OCT at presentation, the optic nerve and maculae were normal. However, 1 year later, although the optic nerve RNFL remained normal, both eyes' inner retinal layers there was GC-IPL thinning, and there was macular atrophy. So the OCT macula at the onset was normal. However, on the infrared images, the right eye was normal. The left eye, the infrared images show some bright patches. These were repeated 2 months and 8 months later, and they were exactly the same. So the outer retina was an ellipsoid zone remained normal, and the infrared images also remained normal. So we did some, the visual field confirmed the bilateral central scotoma, and at that point we're thinking, well, this is probably a bilateral maculopathy, possibly an occult maculopathy. So we did perform some electrodiagnostics, which showed the patent ERG showed both decreased P50 and 95, consistent with the retina course. The scotopic full field ERG showed borderline rod and combined responses, but the photopic responses showed decreased cone and 30 Hz flicker. So there was global cone dysfunction. Eventually, he had some genetic tests. Perhaps Dr. Carey can elucidate us on these later. So in fact, there were 2 abnormalities identified. He was heterozygous for BEST1 variant and also heterozygous for the ABCA variant. So the best disease variants, when we looked it up in the literature, there could be, it's associated with a variety of diseases, but phenotypically, the patient did not display any of these. Whereas this was, there's a variety of diseases which can be caused by this variant, and I think cone rod dystrophy amongst the list could fit this patient best. So so before I move on to my take-home messages, I just want to make a note about neuroimaging, because optic atrophy can be interpreted as optic neuritis. So the increased T2 from the CSF can mimic acute optic neuritis, but of course the history, well, you need to go back to the history, and also the contrast is very important, because if you sit on contrast scans and if you just look for the T2 hyperintensity, this may not give you sufficient information. So, but if you have T1 weighted images with contrast, with optic atrophy, there's no contrast enhancement, whereas in acute optic neuritis, there would be. So quickly, take-home messages. Are the signs and symptoms consistent with optic neuropathy? Is there pain associated with extraocular movement? Are there positive visual phenomena like photopsia, and metamorphopsia, which are characteristic of maculopathy and retinopathy? And next, confirm your diagnosis with ocular neuroimaging and also electrodiagnostics. So retinal diseases, bearing in mind, retinal diseases can cause optic neuropathy, but there can be decrease in VEP for both retinal and optic nerve diseases, whereas in optic nerve diseases, the retinal full field ERG should be normal, and beware of over-interpretation of neuroimaging. And nowadays, we have genetic testing available for retinopathy, maculopathy, and optic neuropathies previously of a no course. So thank you, and feel free to ask me any questions. Thank you.
Thank you, Dr. Carmen. You did such a great job of clearly trying to distinguish in our
I
minds.
can't hear you because, let me see what I could, I ran out of battery in my earphone. So in fact, perhaps maybe come back to me later. Maybe do come back. Maybe come back to me later because I can't hear you. So
Yeah,
I'll stop
but it was
sharing.
an amazing talk, and so much of information was given in the last 10-15 minutes about retinopathy, and it was truly a talk to be remembered and heard again. Thank you very much. Do we take some discussion? I think she has some problem.
Battery issues. Yeah, battery issues.
Battery, yeah. So we can have a discussion with the other expert panel. Murli, can you take it on?
Yeah, I have a question. If Dr. Carmen, you're online, you could answer. And do we routinely get a RAPD in patients with azure, acute zonal occult outer retinopathy?
Oh, she's not able to hear it.
I can answer because I also do retina.
Yes.
and a little uveitis. So it depends on the extent of the visual field loss and the asymmetry. At Iowa, they use the neutral density filter, and it turns out one quadrant of peripheral retina is equals 0.3 log unit RAPD, and the macula is worth 0.6 log unit RAPD. So 0.3 is kind of like a trace to 1 plus, and 0.6 is probably like a 2 plus RAPD. So if it's a bilateral azor, you may not see it. If it's a enlarged blind spot type of azor, you may not see it. But if it's pretty extensive, you can. So it just kind of depends.
Thank you. Dr. Carmen, can you hear us now? Apparently,
Yes,
you have
sorry
anything
about that.
else? Yeah. So anything to add, Murli, before we go on to our next talk?
Yeah, I just wanted to ask you, Dr. Kamen, in carcinoma-associated retinopathy, do you test for a panel of antibodies? I mean, what do you do?
Yes, I only do well, I do send for an anti-retinal antibodies panel, but as shown in a paper by Dr. John Chen a couple of years ago, the only anti-recurrent antibodies is quite specific and pathogenic. That sometimes they can identify some other anti-retinal antibodies, but some of them are not always pathogenic.
Thank you. Thank you, Dr. Carmen. So, Dr. Drew, we would take on your next talk on radiation optic neuropathy, evaluating and managing therapeutic dilemmas. You could take the talk now? Doctor, yes, doctor.
Yep, thrilled to. Let me get this going here. Is that showing up okay? So there we go. So I'm gonna talk about some pitfalls and pearls in the diagnosis and treatment of radiation-induced optic neuropathy. I have no financial disclosures for this talk either. This is a big talk, so I tried to limit it to fit in the time span and get some good teaching points. For the basics, why do we care about radiation? Well, radiation is commonly used to treat head and neck and CNS tumors, including malignancies and some benign paracellular tumors. We commonly see things like meningiomas, craniopharyngiomas, unresectable pituitary adenomas. These treatment areas often overlap with the optic pathways, and radiation damages the DNA, limiting cellular replication. And vascular endothelial cells are some of the most radiation-sensitive non-malignant cells. And damage to these endothelial cells results in endothelial cell dysfunction, which is marked by ischemia, as well as leakage, which can then secondarily compound the ischemia in these damaged blood vessels. And as the optic nerve has a high metabolic demand and it's prone to watershed ischemia, it is highly vulnerable to radiation damage. So we're going to go over some pitfalls and pearls. The pitfall number one is neuroimaging. Don't trust your radiologist. I think Dr. Chan alluded to this a little bit in her discussion. I like to tell my residents and fellows the MRI is not normal until the neuro-ophthalmologist has reviewed the films. Neuroradiologists are great at looking at brains, but they don't spend a lot of time looking at optic nerves and orbits. The neuro-ophthalmologist is the only clinician who has a good understanding of the clinical presentation, localizing the disease for the vision loss, and the experience of looking at optic pathways to look for the areas of damage, particularly when the radiologist sees, oh, it's follow-up of a brain tumor. They're just looking to see, is there new brain tumors, their brain tumor bigger? They're not looking for the complications of radiation. Optic neuritis on the radiologist report means the optic nerve is enhanced, or maybe it's just a T2 hypersignal. It does not necessarily mean the cause is inflammatory. So if you're thinking the patient may have a tumor, an infiltrative process, radiation damage, and the radiologist says optic neuritis, don't let that dissuade you from your differential. And then you have to make sure that we're ordering a brain and orbits protocol, thin slices with fat saturation. I think you all probably know this better than most, but our colleagues that we share these patients with, the radiation oncologist, the neuro-oncologist, the head and neck surgeons, They just order MRI brain. And it's not detailed, and they have not alerted their radiologist that there's a vision problem and it needs to be protocoled, and then they have clinical attention paid to that. So that's why it's really important for you to look at your own films for these patients. Pearl number 1 in neuroimaging, radiation optic neuropathy changes on the MRI are very focal. They're limited to the intracranial prechiasmatic optic nerve, and it may not be a thick solid enhancement that we're typically see for in our optic neuritis patients. It may be focal nodular enhancement like we see here and like we saw on this case. It was not a full thickness optic nerve. The optic nerve enhancement can precede symptomatic vision loss. So when I have these patients come in for monitoring and they've had their MRI scans that they're doing for monitoring the tumor, you always want to look at that even if the patient is not reporting any vision problems. And sometimes, in rare cases, the MRI may show diffusion restriction without enhancement, and that can still be consistent with radiation optic neuropathy because they're having ischemia of the optic nerve. Pitfall number 2 is related to treatment. You do not want to treat with steroids or hyperbaric oxygen or pentoxifylline and wait to see if the patient responds. There's been numerous studies showing that anti-VEGF treatment is superior to steroids and hyperbaric oxygen for radiation necrosis. We don't have as many detailed studies looking at it specifically for radiation-induced optic neuropathy, but we are extrapolating from those studies because this is a very rare condition. And we've looked at our patients that we treated with bevacizumab intravenously for these intracranial radiation optic neuropathy patients. And we found that 67% of patients, 2/3, were able to stabilize their vision, but improvement is rare. So you don't want to wait for the patients to get worse because that's vision that's lost. You're not going to get back. You want to be aggressive with these patients. Pitfall, the additional pitfall related to treatment is assuming that just because there's optic disc edema means that the damage is restricted to the optic nerve head. They can have optic disc edema and retrobulbar nerve involvement as well. Pearl number 2, give the bevacizumab where the radiation damage is occurring. For anterior optic neuropathy, it's only involving the optic disc. The MRI shows there's no retrobulbar enhancement. You can treat those patients with intravitreal therapy. This can help to avoid systemic side effects that could limit treatment. And it's also much easier to arrange because this is something retina specialists are doing regularly. If it's a retrobulbar optic neuropathy, we're seeing those typical MRI findings in that intracranial prechiasmatic optic nerve. You'd have to treat those patients systemically. The amount of bevacizumab you're going to put in the eye is not going to get all the way back to the chiasm, and the dose is not high enough. So anterior radiation optic neuropathy is a papillopathy. This is intravitreal bevacizumab. I use 1.25 milligrams per 0.05 milliliters. Given every 4 to 6 weeks until the disc edema resolves. It often takes 4 to 6 months of treatment before the disc edema resolves. This is the exact same dose that's used for retinal conditions like vein occlusion, diabetic retinopathy, exudative macular degeneration. Once the disc edema is resolved, you can consider either a treat and extend protocol, so continue treatments but spread out how often they are, or you can switch to PRN protocol where you monitor them monthly for about 6 months and see if there's any recurrence. For retrobulbar involvement, there's various protocols that have been described. They've not been compared. We don't know which is the most optimal protocol, but you do have to give intravenous systemic bevacizumab. Most commonly, it's used 5 milligrams per kilogram every 3 weeks for 4 cycles. There is a version used in pediatrics that's intra-arterial combined with mannitol at a lower dose. I'm not going to get into the details of that. Here are a few cases of radiation-induced optic papillopathy. It may mimic NAON. So there's going to be disc edema. It may have hemorrhage within the disc. You can see on this near infrared all of this, on this red-free photo, all this hemorrhage inside the disc and the blocking on the floor seen from the hemorrhage. It's often a prolonged course of disc edema. So if you're saying this is NaON and you're monitoring it, I mean, that disc edema may persist 3, 6, 12 months. So a little bit atypical. There's often peripapillary exudation with cystoid fluid, subretinal fluid, and exudates. Here you can see the exudates in the macula and the subretinal fluid extending here. And there may be an associated vitreous hemorrhage from breakthrough over the disc. Here are a few cases from acute presentation. You can see the cystoid changes in the intraretinal hyperreflective foci for the exudates. In the nerve, this patient was treated with a treat and extend intravitreal bevacizumab. They received 8 treatments. The disc edema went away and the intraretinal fluid went away. The field remained pretty good. Visual acuity went from 20/30 to 20/25. For a patient with radiation optic neuropathy who had received 72 gray, I consider this a win because they didn't go blind. This is a potentially blinding disease. This is a 62-year-old patient that presented 4.5 years after 72 gray of radiation. The presenting visual acuity was 20/25. The disc was markedly swollen. You can see subretinal fluid, intraretinal fluid, exudates. They were treated 9 times on a monthly treatment, and then treat and extend. The disc edema went away, the fluid went away, the subretinal fluid went away. The vision was maintained at 20/25 in this eye. And this is a third patient who presented 2 years after 72 gray of radiation. 62-year-old was 2100. There was vitreous hemorrhage, which is why this is so hazy, and there's intraretinal fluid causing thickening. They received 7 treatments. The hemorrhage went away. The intraretinal fluid went away. Their visual acuity improved to 20/50. Field was not terrible. Some of that improvement in the vision was probably related to the resolution of vitreous hemorrhage. But again, they didn't go blind. I realize these are not these are not randomized. They're not controlled because we don't usually monitor these patients and they're rare. Pitfall number 3, missing other causes for vision loss. Just because a patient had radiation and has vision loss, it doesn't mean it's from the radiation. They can have other causes or concomitant causes. If the radiation was anterior for like a paranasal sinuses, they can have concomitant radiation retinopathy with cystoid macular edema, ischemic maculopathies, proliferative retinopathy with a variety of complications. They can have complications from their other therapies, such as immune checkpoint inhibitors, chemotherapies. They can have opportunistic or reactivated latent infections in these immunosuppressed patients. And patients, particularly with head and neck cancers, when they're getting chemotherapy and radiation, they're not eating well. So they can develop nutritional deficiencies as they're malnourished. They can have complications of their disease progression, leptomeningeal carcinomatosis, optic nerve infiltration, elevated ICP. That can be from tumor or it can be from radiation brain necrosis. They can also develop compressive optic neuropathies from their tumor progressions, or it could be true and unrelated. These patients can also get NaON, although you'd think it would be atypical for patients to develop NMOSD or MOGAD when they're on immunosuppressive chemotherapies, right? Their immune checkpoint inhibitors may unmask something like that. Pearl number 3, for monitoring these patients. Since the treatment rarely restores the vision, early diagnosis is key to preserving vision. So I like to monitor the patients who are at risk of radiation optic neuropathy. It's important to coordinate with your radiation oncologist so that they're referring the patients to you, even if they're asymptomatic, and to make sure you get an understanding of what the dose is to the optic nerve. It's not easy from their notes or from the radiation diagrams to figure that out. But if you just ask them, hey, what was the maximum dose to the optic nerve? That can help re-stratify them. And then you have to counsel the patients on the symptoms of radiation-induced optic neuropathy and make sure they understand it's an emergent need for evaluation if they're experiencing vision loss. So this is an interim results from a meta-analysis we're currently processing. And you can see that the risk of radiation optic neuropathy is dose-related. The higher the dose, the higher the risk. And even patients receiving relatively low dose 50 to 54 gray to the optic nerve sheath meningiomas, they were still at about a 4% risk in the meta-analysis out of 477 patients. So how do I interpret these results? How does this change my monitoring protocol? So I start the monitoring protocol 6 months after they finish their radiation. If their risk is less than 5%, less than 65 gray to the optic nerve, I see them annually for 7 years. If its risk is between 5 and 10%, or they got 65 to 70 gray, I see them every 6 months for the first 2 years, then annually. Or if they got whole brain radiotherapy, because we're not sure the exact risk for these patients, but it appears higher than standard than you might expect. I see them every 6 months for the first 2 years. For patients whose risk is greater than 10%, so they got greater than 70 gray or they had to be retreated for recurrent cancer, I see those patients every 3 to 4 months for the first 2 years and then every 6 months. In summary, you have to have a high index of suspicion for radiation-induced optic neuropathy for patients who either present with swollen optic nerve or rapid vision loss who have a history of head and neck or CNS radiation. The radiation-induced optic papillopathy may mimic NAON. You have to review your MRIs yourself. I'm probably preaching to the choir with that one. There is treatment for radiation-induced optic neuropathy. It may be local versus systemic anti-VEGF, and we are better at preserving vision than restoring vision. So you have to diagnose them early and get them treated quickly. Things we did not get into detail when you're discussing treatment of patients with tumors near the optic nerve with your radiation oncologist. You want to avoid stereotactic radiosurgery, often abbreviated as SRS. These are protocols like Gamma Knife or Cyber Knife because the dose per fraction is above the tolerance for the optic nerve. And I am not a fan of proton radiation to the optic nerve. I don't think we have a good understanding of the tissue interactions and its risk profile. So I would prefer photon rather than proton radiation when it's coming to tumors near the optic nerve. Happy to take any questions regarding this talk.
Again, another wonderful talk, Dr. Drew. It was so good to hear and understand how anti-VEGF treatment could be given for these patients, and so much more opens up. Murli, would you like to take some question? Could you include our expert panel for the discussion?
Yeah, Dr. Drew, thank you so much for that informative talk. So I had a question. When do you really suspect this radiation optic neuropathy? Like only in radiations to head and neck? I mean, radiations to upper chest and all, usually they say that they shield it so very well that there can be no leak through radiation. So is it always that you get it only in radiations to head and neck?
Yeah, I would be difficult to diagnose a patient with radiation-induced optic neuropathy if they were not getting radiation above the clavicle. You can talk to the radiation oncologist and say, hey, what was the dose that got to the optic nerve? Unless it's a whole brain radiation where they're doing a dose of higher than 3 fraction per gray, and actually it's higher than 2 fraction per gray is the cutoff for optic nerve tolerance. The total dose, under 50 is exceptionally rare. Total dose to the optic nerve is exceptionally rare. The patients where they get scatter from chest radiation are patients who have like pacemaker implants. But usually they're not going to do radiation to those patients because of that. So I think if it's something, if you're having vision loss and you did not have radiation where the optic nerve was in the field, or the dose to the optic nerve was less than 50 gray, you should really investigate other causes. Yeah.
Do you ever diagnose radiation optic neuropathy when the MRI is normal and the optic nerve head is also normal? Can you still suspect a radiation optic neuropathy, especially if the other causes are a little unlikely?
I think if you can get a good quality MRI scan with diffusion imaging of the optic nerve, you can see ischemia, diffusion restrictions suggesting that there's ischemia there. I do have a patient where that happened for whole brain radiation, and there was not enhancement. They did have changes in the retina, suggestive of radiation retinopathy, and he looked like there were changes in the optic nerve head. You don't have to have those changes in the optic nerve head, but sometimes it's difficult to get a good diffusion scan in the orbits because there's a lot of artifact and distortion. So you can try. I guess like in other diseases, you have definite and you have highly probable and low probable. And the challenge in treating patients systemically with bevacizumab, if you're not 100% sure, is there's risk for complications, renal injury, hypertensive crises. So you can try and you can try the treatments and monitor them, but you would definitely want to make sure that you've ruled out other other causes. I guess they're kind of like saying, you know, is it possible to have optic neuritis without optic nerve enhancement? You could say, yeah, kind of, maybe.
Thank you. Thank you, Dr. Drew. We shall go on to our next speaker, Dr. Ambika, who's a senior consultant neuro-ophthalmology from Shankar Nethralaya, Chennai. And she's going to take us again to a very relevant talk, toxic optic neuropathies, recognition, causes, and management. So on to you, Dr. Ambika.
Thank you, organizers, for this opportunity. Sharing my screen. So I'm going to talk on toxic optic neuropathy recognition and management. I have no financial disclosures. In a nutshell, I would end my presentation with this slide too. You identify the toxic agent, stop it, wait and watch, and supplement with sufficient vitamins and antioxidant. I think I'm done with my talk, Dr. Chitra. So that's the most common way of managing a toxic optic neuropathy, unless proven otherwise it is the cause for the vision loss. So toxic optic neuropathy is something where the patient comes with gradual visual drop. And most important is getting the history from the patient that he is or she is having that drug or being exposed to that toxic agent. So most commonly, it causes a papilomacular bundle damage. So it causes a central centrocecal scotoma. And the pattern of involvement is painless, progressive bilateral visual loss. Most of the time, it's symmetric, and color vision loss is usually disproportionate to the vision loss. The range of the relative scotoma can be different, and sometimes it can cause to a complete blindness. And most commonly, we see less than 2400 vision presenting to us. And since it's bilateral involvement, we don't get to see a relative afferent effect. Maybe if it is an asymmetric involvement, but none other than we always see a sluggish reacting pupils in most of these cases. And optic disc appearance depends on how soon the patient comes to us. And in the early stages, they can be near normal, or sometimes we can see a swollen or hyperemic disc also in the early stages with hemorrhages. But most commonly, we see a gradual visual drop, and so we end up seeing them as temporal pallor or a diffuse pallor. So this chromatopsia is the first symptom, and particularly the red desaturation in most of the toxic optic. So these are the differentials which we would think in terms of a toxic optic neuropathy, starting from nutritional to hereditary. We had one talk earlier. So, and another important thing is most of these toxins can act as stressors. Metabolically, they can trigger an underlying mutation and result in an optic neuropathy, which can be of a hereditary etiology. So you have to be very careful in making a diagnosis of toxic optic neuropathy in the preceding of inherited or lawn or any type of hereditary optic neuropathies. The other etiologies can be a compressive or infiltrative lesion of the chiasm, bilateral inflammatory demyelinating neuritis, maculopathies, and retinal degenerations like cone dystrophy, what we heard, a very nice talk from Dr. Carmen, and non-organic visual loss also is possible. So toxic optic neuropathy is a diagnosis of exclusion. So I've just shared few common causes of toxic optic neuropathies, what we come across in our clinical practice. These are the list of drugs and toxins which we do end up seeing in our clinical practice. So a detailed history taking and finding out the nature of the vision loss. Other than the methanol poisoning, most of these toxic agents do cause a very gradual drop in visual acuity. So the examination includes a detailed vision, color vision, pupillary examination, anterior and fundus examination. Electrophysiology has its role, and definitely VEP, ERG, particularly the multifocal and the full field ERG has a role in such cases. And to differentiate whether are we dealing only with an optic neuropathy or a maculopathy, OCT and electrophysiology will be very helpful other than our classical Humphrey visual field analysis and AMS loss, if at all the patient is not able to do the visual acuity field assessment. Confrontation can be helpful in those conditions, and otherwise we have a very nice automated perimetry which we can use in the follow-up to see the change in the pattern of the visual field loss. So MRI brain and orbit, yes, may be useful to exclude the other causes which we suspect in such conditions. VEP will have in early phases a normal latency, but there can be a remarkably reduced amplitude. And as I mentioned, ARG will be helpful in differentiating a retinopathy versus optic neuropathy. So methanol poisoning, in the acute stage, we generally don't see them that frequently presented with ophthalmic unless it's a multidisciplinary specialty where they deal. So it can be a sporadic inadvertent suicidal ingestion of this toxin, which can have a severe GI symptoms with a headache, shortness of breath, abdominal pain, confusion, and severe visual loss. In the acute stage, it's a profound loss which is painless, fixed pupils, dilated pupils, and the fundus can show an acute hyperemic optic disc edema. And in the serum, we may have a metabolic acidosis, which has to be dealt immediately because of the fomite accumulation. We might have to consider omeprazole, folate supplementation, bicarb, and hemodialysis. But coming to the neuropathy, it is general vision prognosis. It's quite not that great, but there are reports saying less than 3 weeks, they can consider for erythropoietin, steroids, and all intravenous, which has proven to be having some amount of visual recovery. There are few reports saying that. And coming to ethambutol, which is the most common toxic drug which we see in our country, almost 6% of the patients on antituberculous regime do develop this toxic optic neuropathy due to ethambutol. And invariably, the dose is somewhere between 15 to 25 milligram per kg per dose. And it can go up to 35 milligram per kg because as the dose is escalating and with the longer duration, we have to be very cautious that the patient is going to turn back having an ethambutol toxicity. So most of the times we end up seeing ethambutol toxicity after 2 months of the treatment. And the common pattern of visual fields is central cephal scotomas, and bitemporal defects can also be seen in many times. And the pattern of recovery, what we come across is a very slow, gradual visual recovery over a period of 6 months to 1 year. So let me make one point clear, is our Indian TB NTEP, which is a national TB elimination program, has come up with a revised protocol for TB medications where we give both an intensive phase as well as the continuation phase ethambutol. So that is something which we practicing in India are very much worried because the dose escalation for a longer duration is going to definitely come up with more and more ethambutol cases unless they are being informed the possibility of having the same. And this protocol also says that there is a special consideration for intraocular TB where they have only 2 months of the intense therapy where ethambutol, and you can revise it only to 2 drug for the subsequent phase. But that is for the intraocular TB. So we try to analyze our group of people, how the visual recovery is happening in these toxic optic neuropathy secondary to ethambutol. We analyzed in our patients and found that elderly age group patients with low BMI, poor renal function, associated other secondary infections did have a very poor recovery in spite of stopping it well ahead. And next comes isoniazid, the most common second-line drug, which causes toxicity. Here we have an associated bilateral optic disc swelling. It can also produce bitemporal immunopic scotomas, and the vision improvement is watched usually when the drug is stopped. And paradoxal supplementation can stabilize or reverse the toxic effects. But both ethambutol and INH concurrently used in ATT is definitely a problem when to stop which. But we do go with ethambutol to be stopped first, and then we wait and watch by 4 to 6 weeks. If the vision drops is stabilized, then we continue with INH. If not, then we go ahead and stop INH too. So coming to linezolid, which is one of the oxazolonide antibiotic, which is being used as a second-line drug for the multi-drug resistant TB, which is not uncommon in our country again, because we have a lot of TB osteomyelitis and very severe miliary TB where they could go for the second-line therapy. And linezolid associated toxic optic neuropathy has been used even with a linezolid of less than 5 minutes use. So in most of these cases, stopping the drug, the vision can improve, but sometimes the central visual acuity remain to have, not cleared. And again, a mitochondrial dysfunction can be a precedent in most of this toxic optic neuropathies. So the chemotherapy agents, these are the list of chemotherapeutic agents. Other than toxic optic neuropathies, they can have secondary demyelinations and combined vascular occlusions and macular toxicity. And this group of TNF-alpha inhibitors can result in central or peripheral demyelination secondary, which can also cause some sort of an optic neuropathy. I'll just quickly rush few cases. This is a 44-year-old female with a gradual drop in vision in both eyes, 3/60 and near normal fundus with a severe color vision loss and a sluggish pupil. She gave a history of ATT for 7 months and stopped 10 days back ethambutol. So this is the pattern of the visual fields, what we see, dense centrocecal defects. And after stopping the ethambutol, she did recover by 3 months to almost 6/9 equal in both eyes. And there's also good resolution of the visual field loss with supplementation. And this is a 53-year-old male with complaints of a left eye drop in vision. He was diagnosed elsewhere as optic neuritis and he was advised for steroids. But he had some cardiac problems and he was an hypertensive. So there was a dilemma whether he's really having optic neuritis or is he having an ischemic optic neuropathy. And that's the reason why he was referred to us. So when I saw he didn't have only in one eye, he had bilateral disc edema and the color vision was slightly better and sluggish pupils with inferior altitudinal, and this is the fundus appearance what I could see in both eyes. And then he revealed that he's a known patient of AF and he's on amiodarone. So we should not forget this amiodarone as a cause of bilateral disc edema in group, which is more prone to have an NAION, and these are the differentiating factors. So remember amiodarone optic neuropathy, and most of the time these optic neuropathy can cause protracted disc edema, unlike an NION, which usually resolves in few weeks. So this is a guy who was having a NDR-TB. He had a bilateral dropped vision to 6/18 and 6/9 with a dropped color vision. He was on this entire list of antituberculous therapy. He was an osteomyelitis case because of a poor recurrence, and he was also started on that. So subsequently, this is the way he presented to us with the very minimal hyperemic disc edemas in both eyes and bilateral dense central field loss. So that was a provisional diagnosis of linezolid toxic optic neuropathy. After stopping linezolid by 3 to 6 months, he did recover, but the central visual field defects did persist. And this is a 48-year-old female who was having a very mild drop in vision. And she was very symptomatic because she had, following a fever, this dropped vision, and she had a significant color vision drop too. Her fundus revealed a bilateral temporal pallor and a very subtle central depression and not a great. In fact, she was referred as optic neuritis and she was advised for a second-line treatment elsewhere. But she had a VEP which showed reduced amplitude and delayed scotopic responses and grossly reduced MFERG responses in both the eyes. And only then she said that she's been on HCQ for a long time and she did have this type of vision loss even earlier, and it is not very high only after the fever. So we should not forget that toxic maculopathy secondary to HCQ is quite common and it can be mistaken as optic neuritis or any other type of toxic neuropathies. This is the last case, which I'm going to say. This is a 56-year-old male who came with a bilateral progressive drop in vision over 7 months. And he was a known case of acute promyelocytic leukemia for a year. And post-bone marrow biopsy, he was on chemotherapy. He was on all transretinoic acid and injection arsenic trioxide with a low dose of steroid. And he completed the therapy 10 months back, and he started developing the visual loss since then. And bilaterally sluggish pupil with a 3/60, 6/60 vision and color vision also poor. This is the fundus appearance. He had almost grossly normal retina and a very subtle temporal pallor in both eyes. And this is his visual fields. He had a bilateral central scotoma, delayed latency and amplitude on VEP, and ERG full field, grossly normal, but MPRG showed mild reduction in responses. And there was a dense ganglion cell and loss also on macula, OCT, and MRI brain in orbit was normal. So our provisional diagnosis was toxic optic neuropathy secondary to arsenic use. And we have been discussing with the hemato-oncologist, is there possibility of any antidotes or dialysis or anything. And we also did a genetic testing and ruled out a mitochondrial association, but the patient is on a low dose of steroids and he's going to come back for a follow-up maybe shortly. So I conclude with this take-home message that toxic optic neuropathy can reverse if you identify the toxic agent earlier, and sooner we stop, the vision recovery can happen. And it is most of the time dose and duration of the drug which is going to decide the visual outcome. We need to pull out the detailed history of the drug details from the patient. And all patients should be screened for maculopathies and other causes which can mimic a toxic optic neuropathy because it's a diagnosis of exclusion. Adequate multivitamin and toxicity supplementation can help us to a certain extent. And of course, CE MRI can, contrast enhanced MRI is useful in many times to rule out the other causes for this. Thank you so much for listening.
Thanks a lot, Dr. Ambika. That was a amazingly thorough talk. And but only thing, we are running quite late. We have 3 more speakers. So I think, Dr. Murli, we shall take all the 3 talks and then come back with the questions. We go on to our next speaker, Dr. Durga Priyadarshini, who's the Deputy Director in Shankar Nethralaya, the Department of Neuro-Ophthalmology. And she's going to give us clinical insights and diagnostic pearls for the pupil in neuro-ophthalmology. So on to you, Dr. Durga.
Thank you, ma'am, for the kind information, kind introduction. And I just want to know whether my slides are visible.
Yeah, visible. Yeah.
So my topic for today
We'll have to
is...
stick to our time clearly. And Vel Murugan, please keep us updated because I don't want other speakers to feel delayed. Yes.
So my topic for today is pupil in neuro-ophthalmology. So I'll be talking about the clinical insights and the diagnostic pulse. So to start with, pupil is a window to the brain, and as it tells us about the intactness of the visual pathway, autonomic nervous system, cranial nerves, and also the brainstem. So 3 important parameters are to be assessed when you're evaluating a pupil: the size, shape, the light reflex, and the near reflex. So in today's talk, I have 3 sections to be covered: pupil in efferent pathway lesion, pupil in efferent pathway lesion, and pupil in comatose patients. So let's move on to the first one, the pupil in efferent pathway lesion. So relative efferent pupillary defect is a sensitive indicator to check for the efferent pathway dysfunction. And it compares the optic nerve function between the eyes, and for which one functioning pupil is required to check for an RAPD. So RAPD can be quantified by using a neutral density filter. So there are some variations in swinging flashlight test. That is, when you have an abnormal pupil, either because of any structural damage of the pupil, or if you're not able to visualize the pupil due to corneal opacities, then in that case you have to check for inverse RAPD. That is by checking the consensual reflex in the other eye. And remember, in ocular misalignment, always stimulate the eye of the squinting eye along the axis of the squinted eye, because it can induce a false positive test in the same eye. So the causes of RAPD can be mostly it is unilateral or asymmetric optic nerve function defects, and however it can be present in severe retinal disorders, amblyopia, or media opacity secondary to vitreous hemorrhage or total cataract. And very characteristically, optic tract lesion can produce a contralateral RAPD. And can there be an RAPD with a normal vision and a visual field? Yes, that's called as a tectal RAPD, which localizes to the dorsal midbrain because of the lesions of the edge-of-vespal nucleus, and they do have associated features like gaze palsy, convergence retraction nystagmus, or absent convergence. Moving on to the next section, that is the pupil in efferent pathway lesion is very important. So they present with unequal pupils, that is called as the anisocoria. Usually, if the difference is less than 1 millimeter, it's mostly physiological. But if it is more than 2 millimeter, we call it as a pathological anisocoria. When you're evaluating a patient with anisocoria, first rule out any structural defects in the iris. So a proper slit lamp examination is very important, and then look for whether the anisocoria is more in dark or more in light. So when anisocoria more in dark, that is the abnormal small pupil is failing to dilate in the dark. See how is the light reflex in such pupil. So the small pupil with poor light reflex, check for structural changes. Again, rule out any damage to the iris secondary to any uveitis or pseudoexfoliation, and then check for the near reflex. If the light reflex is poor but the brisk near reflex is present, probably it suggests of light near dissociation. You have to rule out the Argyll-Robertson pupil or the AR pupil, and so one has to rule out neurosyphilis. And if the light reflex is poor but has a slow and sustained near response, and this also suggests of light near dissociation, but it characteristically, this point differentiates between the AR pupil, and you have to look for sectoral palsy, which can point towards the chronic tonic pupil, or which is commonly called as little old ladies. And in case a smaller pupil has a normal light reflex, it could be physiological or it could be a Horner syndrome. So you have to look for subtle signs like ipsilateral mild ptosis, enophthalmosis, or anhidrosis. And very classically, they can have dilation lag, which is characteristic in Horner's, where there is slow redilation of the abnormal eye. So Horner syndrome is an interruption of the sympathetic pathway of the head and the neck. And it's a 3-neuron pathway with 2 relay centers, which is the ciliary spinal center of Budge and the superior cervical ganglion. And there are some certain pharmacological tests which are mentioned in the textbooks, though they are not practiced routinely. Cocaine, because of label substance and it's not been routinely used, I'm not mentioning here. But aproclonidine can be done to confirm the Horner syndrome, where it causes reversal of the anisocoria or dilation of the abnormal pupil, which is secondary to the denervation sensitivity. But understand, for this process, it needs some time to develop. So in cases of emergency, like in carotid dissection, we cannot perform an aproclonidine test. So in that case, you have to diagnose and localize clinically. So for clinical localization, we have to see whether it's a central or a preganglionic or a postganglionic Horner syndrome. In cases of central Horner syndrome, one can have a brainstem and spinal cord signs. Whereas if you're suspecting a preganglionic, usually they do have history of neck or shoulder trauma or any surgery and changes in the voices. And if you're suspecting a postganglionic Horner's, patient can present with ipsilateral facial pain or headache, and dysphagia or dysgeusia can be present in such patients. So apart from these, you should also check for ciliospinal reflex, which is pinching. If you have if you pinch the neck on the same side, they do present that normally they have a dilation of the pupil in both the eyes, whereas it is absent in pre and post ganglionic Horner's and intact in central Horner's. So pertaining to imaging in Horner syndrome, central and post-ganglionic Horner, you should involve MRI head and neck. And in pre-ganglionic Horners, it is recommended to do MRI neck and the chest. And post-ganglionic Horners, if you're suspecting a vascular problem, MR angiogram of the extracranial internal carotid artery system is recommended. And in pre-ganglionic Horners, if you're suspecting a vascular abnormality, MR angiogram of the aortic arches is recommended. And 2 important scenarios one should remember in Horners is ipsilateral headache, eye pain, and dysgeusia. Along with ipsilateral Horners, an immediate MR angiogram of the neck to rule out carotid dissection is recommended. And in case of middle-aged or elderly with a history of smoking and isolated Horners, better to do an imaging for the chest to rule out lung lesion. If you have a long-standing Horners, be it adult or child, mostly benign, and imaging is not mandatory. But Horner syndrome in children who are presenting with less than 1 year duration needs a special mention. You have to do a complete palpation of the neck, upper chest, axilla, and also the abdomen. And if you are able to localize clinically, and you can confirm the Horners by either doing cocaine or amphetamine test. And remember, amphetamine can be used if the child is more than 2 years of age. And it is a localizable you are confirming the Horner syndrome, then and it's a non-emergent condition, targeted imaging can be done. If it is non-localizable, then it is recommended to do MRI, MR angiogram of the brain, neck, and the chest, including urine vinyl mandelic acid and homolenic acid to rule out any association of neuroblastoma. Moving on to anisocoria more in light, that is abnormal large pupil which is failing to constrict in the light, one have to look for the lids and the extraocular motility abnormalities. If that is present, then it points towards a third nerve palsy, where it is recommended to do an urgent MRI, MR angiogram to rule out any associated aneurysms. And in case the lids and the movements are normal, then and the pupillary reflex is abnormal with a normal near reflex, probably suggestive of a light near dissociation, check for sectoral palsy, which is very classically present and specific for Aedes pupil. We can do a diluted pilocarpine test to confirm the Aedes pupil. And in case if the light reflex is abnormal, along with the near reflex also having abnormality, then it probably suggestive of pharmacological dilation. And in that case, you can do a 1% pilocarpine test. And if you don't find any response that is not constricting, then it's probably suggestive of a pharmacological dilation. In case if it's positive, that is reacting to, it's constricting to 1% pilocarpine, then again, you should think of third nerve palsy. So moving on to the next important section, that is the pupil in comatose patient. It's extremely important for diagnosis and localization. And as a rule, metabolic coma usually has a normal reaction of the pupils and the size, and when compared to the structural lesions. In bilateral hypothalamic lesion, pupils are usually small but reactive due to ocular sympathetic pathway dysfunction. And in uncal herniation, a patient develops usually isolated ipsilateral dilated pupil, and which could be even the first sign of uncal herniation due to compression of the third nerve at the tentorial edge. And in cases of tectal or midbrain lesion, their pupils will be mid position, and the reaction can be poor because of the parasympathetic pathway involvement. And in case of pontine lesions, the pupils are pinpoint but usually reactive. And if the patient progresses to brain death, the pupils are fixed and dilated due to equal abnormality of the parasympathetic and the sympathetic pathway. So I'd like to conclude saying that pupil abnormality is a common finding in eye clinic, and a diagnostic approach is relatively unchanged over the time. A systematic approach in evaluation of pupil will be helpful in diagnosing and localizing them from a benign condition to life-threatening condition. Thank you so much.
Thank you, Dr. Durga. That was another very brilliant talk. But paucity of time, we'll have to hold on to the questions and go on to Dr. Ashmin Gandhi. I'm very sorry, Dr. Ashmin, and due to different requests and your talk kept getting shifted back. I'm very sorry about that. Dr. Ashmin, I've already introduced him, and he's going to talk to us something so very critical and essential in diagnosing corneal sensation as a localizing sign in neuro-ophthalmology. On to you, Dr. Ashmin.
Thank you so much. Thank you, Dr. Chitra. It's always a pleasure and honor to be part of this meeting. Durga, can you stop sharing your screen?
I'm sure we'll have the next 8 minutes.
Sorry.
Wonderful and informative and simple and very elegantly put.
Thank you. Thank you so much. As I said, it's always a pleasure to be part of these meetings where you make it so, the topics that you choose, I think. Can you hear me? Hold on.
You'll have to.
Yeah, just hold on.
Yeah.
So the topic that Murli has given me is a very, as Prem was saying, a lot of times we have a topic where we would have to go ahead and search and topics which are often less talked about. And this is one such topic where corneal sensation and its role in neuro-ophthalmic localization.
Yes.
So let's have first some of the bases of the corneal sensation. Cornea is the sensory part of cornea, is one of the densely supplied tissue in the eye. The sensation from the eye is carried by the long ciliary branches of the nasociliary nerve. The efferent reaches the pons to the trigeminal nerve, the nuclei, and the efferent comes from the facial nerve. And this leads to what is known as a blink reflex. So when you touch the cornea, cornea is really sensitive to touch. It generally causes pain because of the mechanoceptors which are present there. And it's also sensitive to various other stimuli, sensory stimuli. So the efferent arc is through the trigeminal nerve and the efferent is in the facial nerve. The couple of important points and probably which will help us understand this blink reflex. One is the cornea has what is known as the subbasal nerve plexus. So in other words, this plexus has a wide range of area covered by a single nerve fibril. So on the cornea, it's difficult to really localize a lesion, as if if there is an intranasal loss of corneal sensation. Does it mean anything? Not much. The second important point, which we'll talk about in the end of the talk, is that when these nerves enter the cornea, they are myelinated, and just after the limbus, they lose their myelin sheath. So with this background, let's look at the value of this blink reflex or corneal sensation. One more point, how do you really test this corneal reflex? There are two ways. There is a quantitative way and a qualitative way. The quantitative way uses the esthesiometers, like Bonnet esthesiometer. I have no experience of using them. And the usual way in the clinic is using a sterile cotton tip and testing the various areas of the cornea. Thing to remember, especially for the residents who are listening to this, is that we need to make sure that we go from the side or from below, because if we go directly there, the blink reflex is actually stimulated because of the menace reflex. Now with that, let's look at some of the cases and see where the corneal reflex testing would have helped us to differentiate or localize the lesion, because that's the central point of the talk. So here is this young man who, if you see, he was complaining of diplopia in the left gaze. And see, patient looking to the left, there is a complete loss of abduction of the left side, and the right side, there is a nystagmus. In this patient number one, you see here as well, there is a gold weight implant, which has already been implanted in the upper eyelid, implying that patient had leg ophthalmos. So here is a patient who has a 6th nerve palsy of the left side with a 7th nerve palsy and a nystagmus of the right eye. So that's patient number one. Now let's look at patient number two, and then we'll differentiate and see how corneal reflex would have helped. So here is patient number two. Here again, you see here the right eye had a gold weight implant. Now let's look at the ocular motility. So here is a patient looking to the left, and you'll see that the left gaze is fine. And here you will find patient looking to the right. Right eye is not abducting, left eye is not abducting. So we have seen two patients, both had an abduction limitation in one eye and also the 7th nerve problem in the same eye. But in patient number one, you had nystagmus of the other eye, but the adduction was normal. Here in the patient number two, there is limitation of adduction, implying there was a gaze palsy to the same side. So would corneal sensation be of any help? Would it solve this puzzle of localizing lesion between these two patients? Well, it would. Patient number one, you localize the lesion to CP angle, while here, patient number two, you localize the lesion to pons, because patient has a gaze palsy. Remember, the 6th nerve nucleus is in the pons. 7th nerve makes a loop around the 6th nerve nucleus of facial colliculus, and the 6th nerve nucleus generally acts as a gaze center to the same side because of its proximity to PPRF. So if you look at now look at the diagram, we find that 6th and the 7th nerve are close nearby in the pons, implying that in patient number two, there is a likelihood that the corneal sensation would be normal. Versus in patient number one, where you localize the lesion to CP angle, you find here that this is the triangular space is the CP angle between cerebellum and pons, and you find the 5th nerve being here. So, and in this CP angle space, as 6th and 7th nerve progress, and also the 8th nerve, they all would be clumped together. So loss of corneal sensation is much more likely in patient number one versus patient number two. So in other words, you can differentiate between the lesion of CP angle and the pons by corneal sensation, apart from obviously the ocular motility. In fact, in CP angle tumors, there is a possibility that, especially schwannomas, that corneal sensation can be the first sign of these tumors. So patient may have headaches and tinnitus, and the only sign initially can be a loss of corneal sensation. So that's scenario number one, where corneal sensation can be of use to differentiate between two anatomical areas. Now let's look at the second area where all these nerves are bunched up. This is a 42-year-old gentleman who had uncontrolled diabetes, complained of diplopia in the left gaze again. And you find he was told that, oh, this is, and you see here there is again a limitation of the abduction in the left eye. He was told that, oh, this is because of your loss of blood sugar control, and it will become all right. However, if you look at the ocular motility a little more carefully, you'll find that there is also limitation of adduction, minimal limitation of adduction in the same eye, and also the elevation is down. This patient, again, a corneal sensation would be lost. You localize, patient's visual acuity was fine. So here we have a patient who has a sixth nerve, third nerve, and fifth nerve being affected. The possibilities of these three nerves, sixth, third, and fifth nerve being together affected, the possibilities are it can be within the orbit or it can be within the cavernous sinus. Now, if the optic nerve is normal, you localize this to cavernous sinus. Let's look at one more patient of a similar kind of little more severe limitation of ocular motility. Patient had Hereditary. You see here, there is a limitation of adduction of the right eye. You find that the abduction seems to be okay. However, if you look at the eye carefully, it moved a little slowly, and there was a limitation of depression and elevation. Whenever you have this, you look at the involvement of the fourth nerve, you'll find that there is no torsion of the same eye when the patient is looking from up to down, implying that third and fourth nerve both have gone, and also the sixth nerve. This is the patient, again, where corneal sensation, though I don't have a video, would have been affected. Again, you localize it to the cavernous sinus, and this patient actually had a cavernous sinus lesion, which turned out to be aneurysm. Versus, so here is a cavernous sinus diagram, especially helpful for the residents. And you find here that the sixth nerve is within the substance of the cavernous sinus, while the third nerve, the fourth nerve, and two divisions of fifth nerve are all bunched together. So cavernous sinus lesion would have effect of all these nerves, and sometimes also effect on the sympathetic system. Versus a patient who had severe ptosis and complete limitation of ocular motility in all gazes, and this patient also has loss of optic nerve function, implying that you now are localizing this lesion to orbital apex. So in other words, the second area where corneal sensation can be an adjunct to your diagnosis, and in conjunction with sensation testing in other areas of the face, would be this cavernous sinus orbit and supraorbital area. You find here in the diagram that V2 leaves before it reaches the orbit. If the V2 has been affected, apart from other cranial nerves, you localize it, so corneal sensation and also loss of sensation in the lower part of the face. You localize it somewhere outside the orbit, so in the cavernous sinus. But if there's a loss of corneal sensation and other nerves are involved, you know that it's either superior orbital fissure or orbital apex. And this is a diagrammatic representation of corneal sensation. Ophthalmic division of trigeminal nerve, or V1, is where cornea also is included, corneal sensation is included, while V2 and V3 are lower. So that's about localizing lesion using corneal sensation as the sign. Now, can it be false localizing sign? False localizing sign generally be associated with a sixth nerve palsy, especially in raised intracranial pressure. However, when I was digging the literature, I found that the fifth nerve also can sometimes, fifth nerve, loss of corneal sensation can also be a false localizing sign, especially in somebody who is having a tumor in the CP angle or near the brainstem. The reason that it can be a false, so if somebody has, let's say, a left-sided CP angle or brainstem tumor, we expect that the corneal sensation will be lost on the left side. However, if the tumor is large enough, or if it's pushing the brainstem to the other side, then there is a possibility that the corneal sensation will be lost on the right side, and hence loss of corneal sensation in these scenarios can be a false localizing sign, localizing to the area where you don't expect to localize. And this is the last part, as I mentioned in the beginning, that these nerves are myelinated and they lose their myelination just after they enter the cornea. So can it be used as a marker for multiple sclerosis? Where there have been, I found studies where they really mentioned that corneal confocal microscopy, they found correlation between density of corneal nerves and activity of dendritic cells and a disease activity in multiple sclerosis. In other words, they found that multiple sclerosis can have a loss of density of corneal nerves, especially in certain various multiple sclerosis, not all, and not all of these patients would exhibit, however, the loss of corneal sensation. In other words, maybe a little more sensitive quantitative test probably would uncover some of these loss of corneal sensation, which I found interesting. These are many of these were recent papers, so maybe a little more detailed or a little more larger study may help us to have corneal confocal microscopy, the nerves within the cornea, and hence the corneal sensation be used as activity of a disease progression in multiple sclerosis. Please remember, since this talk was limited to localizing it in a neuroophthalmic diseases and only for 7 to 8 minutes, so I've not covered, let's say, neurotrophic keratitis or loss of corneal sensation in aging or in diabetes mellitus. So, in other words, corneal sensation, testing corneal sensation is an easy enough test. It can surely be used as an adjunct to localized lesion in neuro-ophthalmology. I thank Dr. Chitra, Dr. Murli, and entire team at Eye Foundation for inviting me here. Thank you so much.
Oh, amazing talk as expected. Murli, anything to ask before we go on to our last speaker?
Yeah, just a quick comment, RAG sir, that sometimes you see in patients with unilateral LASIK or in patients who have had multiple episodes of herpetic this thing also, herpetic keratitis, they also tend to lose corneal sensations. And when these patients actually develop some kind of a nerve palsy, we get a little bit confused. That was a
Correct.
more of a comment.
Yeah, absolutely. Because as I said, corneal sensation can be lost in some of the local diseases as well. Even stuff like dry eyes and diabetes. So it is basically, when we look at the fellow travelers, is where you say that, okay, this is where you localize. But isolation, just the loss of corneal sensation, may or may not have an impact on, unless, as I said, only reference, and I'm happy to learn from others, but the only reference I found that corneal sensation as the only sign, I found that was part of CP angle tumor.
Any comments, Dr. Drew, on the last two talks?
That was a great talk. I think in addition to its utility in localization, damage to the trigeminal nerve, it's the only sensory nerve other than the optic nerve that's going to lead to vision impairment. And so these patients develop neurotrophic keratopathy, which we now have treatment for with the recombinant neurotrophic growth factor. So you want to pay attention to these patients who have reduced corneal sensation and either monitor them closely or get them to a cornea specialist. If they have, staining that doesn't resolve with lubrication, they need more aggressive therapy because they can go blind. And these patients do very poorly after cataract surgery, especially with topical NSAIDs, this compound that disease. And then we also had a very interesting case of a patient who had neurotrophic keratopathy and trigeminal neuralgia, and their pain improved very dramatically from the trigeminal neuralgia with the use of that topical neurotrophic growth factor. So stay tuned. That may be a treatment coming in the future for our patients who have eye pain, particularly corneal neuralgia.
Thank you.
Thank you. Thank you, Dr. Drew. We go on to our last speaker, Professor Swati Fuljali, who's the Assistant Professor of All India Institute of Medical Sciences, New Delhi. And she's going to be talking on optic neuritis in the new millennium, evolving understanding and management. On to you, Dr. Swati. They always say that the best is for the last. So I'm very sorry that you became the last speaker, but we are all looking forward to hearing a very interesting talk of yours.
Yeah. Thank you, Dr. Chitra, and thank you, Dr. Murli, for that introduction and opportunity. I will be talking about optic neuritis, for how our understanding and our perspective has changed over last few decades. So, Optic neuritis, basically, as with any itis, is an inflammatory disease of the optic nerve, which can be associated with various disorders: CNS inflammatory disorders, systemic inflammatory disorders, and paraneoplastic diseases. So CNS inflammatory disorder basically include multiple sclerosis, neuromyelitis optica, MOG-associated optic neuritis, GFAP-associated optic neuritis. Paraneoplastic optic neuritis, which is now coming in vogue because of more and more treatment available for cancer. So we have the CRMP IgG mediated optic neuritis, which we need to be aware of and look for it if other causes of optic neuritis have not been diagnosed. There could be situation where we have all the antibodies negative and it's known as seronegative optic neuritis. And most common cause for is autoimmune optic neuropathy or chronic relapsing inflammatory optic neuropathy. Optic neuropathy, optic neuritis can be secondary to infection also, viral, bacterial, and it's an entirely different set of presentation and treatment which we need to deal with when we have infectious optic neuropathy. But my talk will be concentrated mainly on the CNS inflammatory disorders or demyelinating disorders, which we commonly see in our day-to-day practice. So, as I said, it can be optic neuritis are the different causes. So, typical optic neuritis and optic neuritis, which is related to MS, while the all other causes of optic neuritis are classified as atypical. Why this classification is important? Because typical optic neuritis, when we say it's an MS-related optic neuritis, the presentation, the treatment, the long-term prognosis is entirely different from the other causes of optic neuritis, and therefore it's clinically important to differentiate the two entities. So a typical optic neuritis where the vision loss is subacute and it peaks over a period of time, say 1 week to 10 days. It is generally unilateral, presenting in a young female. The fundus may show mild disc edema or normal disc if it's a retrobulbar neuritis. While an atypical neuritis will present as a severe vision loss, as severe as no PL. It is usually bilateral, presents with mild to severe disc edema depending on the etiology, and it may have accessory features like disc or retinal hemorrhages there. The absence of pain is characteristic of atypical, while pain on ocular movement is very characteristic of typical optic neuritis. Atypical, it's important to identify because it has very poor prognosis and patient may need long-term steroid therapy. So MS-related optic neuritis, nothing has changed much over the period of over last few years, because as we know, MS in around 20% of cases, it may present as a presenting feature and patient may later go on and develop a full clinical form of MS. 50% of MS patients at their disease, during the course of their disease, will have developed optic neuritis at some point of time. The diagnosis of MS is generally based on the dissemination of attack in space and time, which is either clinically or radiologically. And it's important to understand that the MRI, brain, and orbit is the single most factor that can predict the development of clinically defined multiple sclerosis over a period of time. Now, atypical optic neuritis is, as I enlisted before, the common causes are NMO, neuromyelitis optica, or myelin oligodendrocyte antibodies of associated optic neuritis, autoimmune optic neuritis, chronic relapsing inflammatory optic neuritis associated with other systemic disease or infection. This talk will be focusing on NMOSD and MOG, because those are the things that we are seeing on regular basis. So, as you know, as it was thought before that NMO is rare in India, but now we are seeing that more and more of our patients are generally having either NMO antibodies positive and MOG antibodies positive. The MOG is much more commoner than NMO in Indian scenario, and 20% of demyelinating disorders in India. I'm not saying optic neuritis, in general, all demyelinating disorders in India may be because of neuromyelitis optica or aquaporin 4 antibodies. It has female preponderance as in MS. Generally, the mean age of onset is little older than in cases of MS, where you have second or third decade involved. Here you have third or fourth decade involved. It can present as recurrent optic neuritis. It can present as recurrent transverse myelitis. It can present as longitudinal extensive transverse myelitis or area posteremia syndrome. The antibody-mediated disorder of CNS has predilection for optic nerve, spinal cord, and therefore it presents as optic neuritis and transverse myelitis more commonly. Unlike MS, both gray and white matter are involved in NMO. And what we generally see is bilateral severe loss of vision, and the recovery is very, very poor and needs an aggressive treatment if it is not improving with steroids. While in MS, CSF analysis will show oligoclonal bands. In NMO, generally these bands are not seen, but what we see is pleocytosis with increased neutrophils. So when you have to detect serum and anti-aquaporin 4 antibodies, we have different tests, but the most specific test is cell-based assay test, and it has the greater sensitivity than ELISA or indirect immunofluorescence. So if you have to order NMO antibodies, it's always better to get a cell-based assay than the ELISA test. It has 90% sensitivity as compared to other tests and has 100% specificity. It has to be understood that 20% cases of seronegative NMO may have MOG positive antibodies. So it's important that we order for both antibodies than only ordering for NMO antibodies. So coming to MOG-associated optic neuritis, MOG can present with different clinical features, optic neuritis being one of them. It can also present as encephalitis and myelitis, and therefore has that mnemonic MONAM. So it is generally has very wider clinical phenotype and is more commonly seen in children. It has two peak age levels, so more commonly seen in children or in elderly. It is associated with severe demyelination without astrocyte loss, unlike the aquaporin 4 antibody-associated optic neuritis. So, optic neuritis is bilateral, recurrent. It has long segment involvement, but does not involve chiasma and associated with good prognosis. So this particular table is, I would say, is very useful when we want to clinically differentiate the three types of optic neuritis. Generally, NMO and MS have female preponderance, while MOG generally has an equal distribution of gender. Both NMO and MOG may present as bilateral disease, while MS is typically a unilateral presentation. This vision loss, as I said, is severe to moderate in atypical optic neuritis, while MS will have mild to moderate vision loss. Fundus presentation, you'll have more of a retrobulbar presentation in MS, while in MOG, we have more of a papillitis, that is bilateral disc edemas as a presentation. Myelitis or encephalitis is very rare in MS, but long segment myelitis is very common in NMO, and acute demyelinating encephalomyelitis is much more common in MOG and seen in children. Visual outcome, it is generally good with MS, very poor with NMO, and good with MOG-associated optic neuritis, responds very well to steroids. Relapses in MS are common, but are relatively less common as compared to NMO and MOG. Now, it's the MRI of the orbit and the MRI of the brain, which will help us in differentiating the three different etiologies of optic neuritis till our other investigations are coming to be positive. So MRI becomes a single most differentiating point for the etiological diagnosis of the optic neuritis. So here you have in MS a very focal lesion involving less than 50% of length of optic neuritis, while in NMO you have a long segment involvement of optic nerve, which is more than 50% of length. But interesting thing is that sometimes many a times it may involve chiasma, and sometimes it may go beyond as chiasma and involve optic tract there. In MOG, interesting thing is that even though it's a long segment optic nerve involvement, the chiasma is usually spared, but what is more characteristic is an optic nerve sheath involvement, enhancement, and these perineural orbital fat tissue enhancement can be seen there. Sorry. So you have in MRI also there are differentiating features. The lesions of MS are ovoid, discrete, and characteristically seen perpendicular to the ventricles, generally placed periventricular and infratentorial or juxtacortical area. While in NMO, the lesions are confluent, they are merged with each other, more of a longitudinal lesions and parallel to the ventricle. The common involved areas are hypothalamus, thalamus, pituitary area, area posteremia, and brainstem. In MOG, it is also confluent longitudinal lesions, but commonly seen in supratentorial regions, infratentorial regions, and cerebellum. MRI spine, although we don't order it as a first investigation, but can be done if the diagnosis is not, if you're not able to make diagnosis or if there is a recurrence. And MRI spine generally in MS will have less than 3 vertebrae involvement, which are not consecutive to each other. While in MS and in MOG, you have longitudinal central involvement of more than 3 vertebrae, which are contiguous with each other. Now, the other causes of optic neuritis is associated with systemic disorders like SLE, vaginous, rheumatoid factor, Sjogren's syndrome. Sarcoidosis is pretty commonly seen, and you need to differentiate it with other causes of disc edema, other granulomatous inflammation, particularly tuberculosis, and other choroidal inflammation. So all we need is to do a specific test for each one of them before we make a confirmatory diagnosis. But most of the time, the MRI and the serology will give us the etiological differentiation of optic neuritis. Now, this is a very interesting paper which was published in Lancet Neurol in 2022. This is the collegium of neurologists, neuro-ophthalmologists from all over the world to get a consensus statement about the diagnosis and the management of optic neuritis. So interestingly, this is what they said. They said that any optic neuritis, the clinical diagnosis is made with the monocular subacute loss of vision associated with pain on eye movements and very characteristically reduced contrast and color vision. So the profound loss of contrast and color vision is more common sign of optic neuritis as compared to other optic neuropathies, whether it's ischemic or hereditary. Patient, if presenting unilaterally, will definitely have relative afferent pupillary defect. There can be a situation when the patient has all the features of above, but will not have pain, but should still be considered clinically as optic neuritis. There can be a situation when patient does not have unilateral vision, but has all the features of either A and B and is clinically diagnosed as optic neuritis. Apart from these clinical features, we have ancillary tests like OCT, to support the diagnosis of optic neuritis. So any inter-eye difference of 4% or more than 4 micron in RNFL or GCIPL we should consider the diagnosis of optic neuritis. The definitive diagnosis of optic neuritis comes from MRI, where we see the enhancement of optic nerve itself, and in cases of MOG, optic nerve sheath as well, which can persist as long as 3 months. Then other biomarkers in form of serology like aquaporin 4 antibodies, MOG antibodies, and CRMP5 antibodies should be done to make the definitive diagnosis. So they said a definitive optic neuritis is the one when you have features of A along with only one paraclinical test. So any one of them, if coming positive, we can make the definitive diagnosis of optic neuritis. It can also be made if there are features of B with 2 paraclinical tests positive, especially MRI. It can also be C with at least 2 paraclinical tests, one of which is definitely MRI. So MRI becomes the most important way of diagnosing optic neuritis. Then they classified possible optic neuritis where you have any of the above clinical features, but in absence of any paraclinical test, particularly MRI turning to be positive. So in such cases, it's important to revisit the history, to look at the other differential diagnosis of optic nerve involvement before we definitely make it as an optic neuritis. They also classified optic neuritis as autoimmune and infectious. So what we generally deal with is autoimmune optic neuritis, where you have where I've just spoken about MOG related or NMO related, and clinically it can also be seen as single isolated optic neuritis, recurrent or isolated optic neuritis, or chronic recurrent inflammatory isolated optic neuritis. So investigation, the most important investigation is contrast MRI, contrast enhanced MRI, brain plus orbit. So we have to remember that's not just brain that we need, it's also orbit. And we have to follow the MS protocol, which is flare and fat suppression along with contrast. Apart from that, if we have to order just one other test, it would probably be serology for aquaporin 4 antibodies or MOG antibodies. We can assess the visual functions with the help of other ophthalmological tests like VP, color vision, contrast. This usually help in monitoring more than diagnosis. So how do we manage optic neuritis? Acute episode IV steroid is the norm for optic neuritis, and nowadays we have shifted for 5 days of IV steroids because more and more we are seeing that atypical presentation than a typical optic neuritis. If it is refractory to IV steroids, plasma exchange or IV IgG should be considered, and that decision has to be taken early in the period because any delay in this kind of treatment can lead to poor prognosis. The long-term management of optic neuritis depends on the etiology of optic neuritis, so interferons or other disease-modifying drugs, if it's an MS or diagnosis, autoimmune therapy in form of azathioprine or monoclonal antibodies or mycophenolate, if it is atypical optic neuritis. Particularly NMO, we give azathioprine, and MOG, we give rituximab. So I just want to give three take-home messages. One, the diagnosis of optic neuritis is definitely clinical. But if we want to make the one investigation, that is the investigation of choice, is MRI brain plus MRI orbit with a proper MS protocol, because that's the single most important thing that is going to help us in differentiating three etiological causes of optic neuritis. And it's also one of the important investigation that is going to give us the prognosis for the development of clinically defined MS in long-term course. Second take-home message here would be the second important test that we need to do is a cell-based serology to look for the autoantibodies of NMO and MOG. And it's important to understand that's a cell-based assay that we need to rule out. We also need to rule out the infective causes before we jump on giving steroids. Third important take-home message is high-dose intravenous steroid is the treatment of choice, and the oral steroid should be avoided in the first or the first attack of optic neuritis as an acute treatment. It is definitely, oral steroids are definitely used for the long-term treatment of optic neuritis, particularly MOG optic neuritis, which needs slow taper of steroids over a period of time. If the patient fails to respond to IV steroids, plasmapheresis or IV IgG should be considered immediately. And disease-modifying drugs or immunosuppression have to be considered if there is repeated attack of the optic neuritis or there are any other neurological features, neurological disability that develops as a course part of the disease course. Thank you. मैंने पूरा बोल दिया, मेरा साइन ही नहीं खत्म हो गया.
Swati, that was a very thorough talk and completed it all in exactly 8 minutes. Thanks so much. Murli, you want to have any concluding thoughts on this? Murli, you have to unmute yourself.
What I wanted to say was MOG and NMO and even double seronegative is quite common in our Indian population. So Swati brought up a very, very pertinent point. And live cell-based assay is considered to be the most sensitive and specific test. So NMO we usually treat in coordination with the neurologist, and MOG, yes, 30% of them can have multiple recurrences, and we would like to have a slow taper should it have multiple recurrences. What is important in diagnosing these entities is that disease-modifying therapies for MS can actually worsen NMO and possibly MOG also. So hence it is crucial to identify both MOG and NMO, and we don't have any diagnostic criteria for MOG. We can have a seronegative NMO disease if we don't have a seronegative MOG disease. The entity, as far as I know, has not been defined. Any thoughts, Swati, on this?
Dr. Murali, sorry to interrupt. We do have diagnostic criteria for MOG. I think it was published somewhere last year or 2021, 2022 or 2023.
No,
And
I
they
mean
have
seronegative MOG, seronegative MOG. Like we
so
have a
MOG,
seronegative NMO and
seronegative is negative only. That's what is the understanding, that if you get a MOG which is seronegative, it's probably not MOG because the
yeah,
false
that's what I
positive.
said. Like we have a diagnostic criteria for seronegative NMO, but we don't have for seronegative MOG. You can have a seronegative NMO, like you can test negative for anti-NMO antibodies and still have NMO disease. But it is not possible for you to test negative for MOG. I mean, correct me if wrong, but you cannot test negative for NMO and for MOG antibodies and still have MOG disease. Any thoughts,
Dr. Dhruv,
Dhruv?
sorry, Dr.
Well,
Murali.
no, so I mean,
I-
MOGAD is right. It's the antibody associated disease. So if you had seronegative and you thought somebody might have MOG, they would then qualify as neuromyelitis optica spectrum disorder if they met the diagnostic criteria for that.
Yeah,
I
the
think
thing to
it's
keep in mind. Yeah.
MOGAD is defined as having the MOG antibody. It's MOG antibody associated disorder. So you'd have to either look at your NMO spectrum disorder for the seronegative criteria, or just call it a CNS demyelinating disease.
Yeah, there are a couple of things with MOG as well that it's the one where the CSF can be more sensitive than the serum, but it can be negative in between attacks. And that's the other thing that can be a little bit confusing about it. And so, yes, you cannot give someone the diagnosis without having a positive MOG antibody test at some point in time. But if it's behaving that way, like you suspect MOG, and then they recur, it is definitely worth retesting at that point because the antibody levels are really best detectable at the time the disease is acutely active.
So thanks a lot. It has been a great 3 hours and so much of learning, and I truly plan to share these very good talks amongst our colleagues, and so that it remains with all of us for a longer time. Thank you so much, the expert panel, the speakers, and we look forward to having you all in a different format in future. Thank you so much.
Thank you.
Thank you.
Thanks,
Thank you. Thank you.
Good night.
Thank you.
It was a pleasure to participate. Thank you and for inviting me.
Thank you. Thank you so much.
Bye.
Bye.